understand me now. Sometimes I feel a little mad, but don't you know that no one alive can always be an angel? When things go wrong, I seem to be bad, 'cause I'm just a soul whose intentions are good. Oh Lord, please don't let me be misunderstood.
Você pode pegar do Flora e não ligar. Por favor. Mas, show de bola. Oh, ele tá em Santa Catarina, cara. Tá fazendo uma palestra lá. É? Uai, ele paga, viu? Pô, foi um negócio do Sebrae, será? Pô, tem um tempo isso já, não tem? Foi um dia que tava calor pra caramba. uma outra sala com o
Please don't let me
Pilates.
be misunderstood.
Hã?
'Cause I'm just a soul whose intentions are good. Oh, please don't let me be misunderstood.
Oh, mas eu ia ter saído da cabine, com certeza.
Please don't let me be misunderstood. Please don't let me be.
Olha, a cabine já caiu no meu teto várias vezes, umas 3, vai. Eu não dei ataque. A primeira vez eu gritei, ai Jesus. Foi melhor, foi bom.
She was more like a beauty queen from a movie scene. I said, oh my, but what do you mean? I'm the one who would dance on the floor in a round. She said, I'm the one who would dance on the floor in a round. She told me her name was Billie Jean as she crossed the scene. And every hair turned red eyes, a dream of being the one who would dance on the floor in a round.
People always told me, be careful what you do. Don't go around breaking young girls' hearts. A mother always told me, be careful what you love. Be careful what you do, 'cause a lie becomes a truth. Billie Jean, it's not my love. She's just a girl who claims that I'm the one. But the kid is not my son. She says I'm the one. But the kid is not my son.
Days and 40 nights, I was on her side. But who can stand when she's seen the man, her schemes and plans? 'Cause we dance on the floor in a round. So take my strong advice. Just remember to always think twice. She told my baby we'd dance a treat, and she looked at me and showed a photo. My baby cried, his eyes were like mine. So we danced on the floor in a round.
People always told me, be careful what you do. Don't go around breaking young girls' hearts. She came and stood right back me. Then the smell of sweet perfume. This happened much too soon. She called me to her room. Billie Jean, it's not my love. She's just a girl who claims that I'm the one. But the kid is not my son. She says I'm the one. But the kid is not my son.
Ok. Senhoras e senhores, bom dia a todos, a todas. Com muita
Ladies and gentlemen, good morning. We're very happy to start this day of work today. So, I'm here with Dr. Roberto Yunis from the World Bank. He will be coordinating the next panel. So, without hand the floor over to Roberto so that he can mediate this panel in the morning. Good morning, everyone. It's a pleasure for us to be able to open this panel today for fruitful discussion. So, continuing the international meeting on today, we are going to have 3 panels all throughout the day, and we are going to start with a panel that is going to be joined by speakers from Chile, Mexico, and Argentina. So without further ado, I would like to invite the speakers to come up to the stage, to panel. So Mr. Rodrigo Salinas, he is a physician, surgeon, member of the Advisory Committee of Infrequent Diseases, assistant professor in the Faculty of Medicine of the University of Chile, masters in the University of Oxford and York. He is a director of drug regulatory agency in Chile, and he's also in the Chilean Ministry of Health. I would also like to invite Ms. Andrea Martones. Dr. Martones is a lawyer. She's an advisor of the Secretary of Public Health and Regulatory Affairs, acting in design, preparation of bill and legislation process, and implementation of the system in Chile. Also, I'd like to invite Mrs. Sofia Charvel from Mexico. Sophia is a professor, lawyer, and a coordinator of the public health program in Autonomous Technological in Mexico, and also an academic in the Department of Law in the University of Mexico. Also, I'd like to invite Mrs. Marisa Eidsberg from Argentina. Dr. Eisberg is a director of the Observatory of Health and director of the Research Center in Right to Health in the Yoga Institute in the Law University at the University of Buenos Aires. I would like also to invite Mr. Alejandro Ramos from Argentina as well. He is also a physician, a Subsecretariat of Management of Welfare Services in the Ministry of Health in Argentina. He's a master's in economics and health management, and also in health service administrations. Before we start this session, I would like to clarify some points to the audience, and I apologize in advance that Dr. Mauricio Hernandez had some family problems, urgent problems, and he wasn't able to join us today. So our work methodology that we are going to be using in this panel is going to be the following. We are going to have some discussion, and then we are going to break for coffee, and then we are going to open the floor for Q&A about all the presentations that are going to be given today. So we urge you to participate in this debate. This space for discussion might be the most important times that we're going to have here today. So for us to organize the debate very well today, you can send your questions in writing, and the staff is going to give you some forms for you to fill up with your questions. And if you wish to ask your question orally, this is also going to be possible. If you do want to do so, please make sure to write it down in your form. If you are going to speak and to orally, please try to be as brief as possible to the maximum of 2 minutes so that we all have time to enjoy and discuss the works of this day. So without much further ado, I'd like to ask Dr. Andrea Martones to start her presentation, and she's going to have 15 minutes for that. Good morning, everyone. I would like to thank the presentation from the ALMG and the World Bank. It's not very easy to talk about the Chilean health program in 15 minutes. We divided this explanation a little bit. Rodrigo is going to be talking about this later, and also yesterday Sebastian dealt with some of the topics that we're going to be dealing with today. Of course, we don't have a lot of time. It's not going to be able to be very accurate. So I'm going to talk about the legal framework, which is not very much different from other countries in Latin America. This is guided by the Constitution, international treaties, health normatives. In Chile, we have a lot of legislation, a lot of regulations, technical norms that make it difficult for us to understand the system in Chile. So, as Sebastian said yesterday, the Constitution ensures the right to health. It doesn't, but it ensures the protection to health, which is introduced in the assurance of equality and free access. So the legislator here is saying that there's no assurance of access, but when access does happen, it can't be discriminatory, and it has to be free of constraints. So we cannot ask for a payment guarantee. People have to have access to health care without having to pay for that. The state also has the priority role to execute health care actions. And contrary to the rest of the economic areas of the relationship, the state is a subsidiary. But here, the private system is subsidiary, and the state has a preferential role to take actions in healthcare. And the most relevant guarantee for the citizens is in the current constitution, and there was current during the dictatorship of Pinochet. We introduced the guarantee that people would have the right to choose the health system which they would like to use. So in Chile, we call the system ISAPRE. These are it means that people don't belong to one single system. The Constitution states that this was the beginning of public health in Chile, and during the 17 years of dictatorship, we didn't have a lot of investments in health. So as I mentioned, the Constitution doesn't ensure the right to health care, but it ensures the protection through equal and free access. So the protection was withdrew, and there are many other constitutional guarantees, and people can appeal to court, but the right to health was left aside there. Also, this constitution separated Social Security and health. But as Sebastian mentioned, happened in 2010, there was a constitutional act saying that the right to law would have to be included in the Constitution. Now, these include the right to life, the right to property through agreements. Now, coverage characterization. Sebastian yesterday delved into this topic, so I'm just going to browse it. But I would like to say that this kind of coverage, first, the occupational disease coverage, they were separated from the rest of health. So we have subsidies for work-related incapabilities and disabilities and everything. Now, when it comes to health itself, health can be serviced by the public service, and it can be administered by public or private initiative. This is the AUGI, which Sebastian mentioned yesterday. This is the high cost and diagnostics, and we started this with last year. And we also have subsidies for work-related disabilities. This mingles a little bit with Social Security, and regardless, we have other programs such as the vaccination programs and programs targeting elderly citizens, and we also have programs related to traffic accidents and complementary healthcare systems. Now, today, the complementary insurance in Chile is belongs to the public healthcare system, so that we can have a better coverage also in the private sector. The population in the system varies a lot. About 77% is in the public system, FUNASA, and we also have the ISABRA system, and the smallest part, which is the Army, Navy, and Air Force, and they are the smallest portion of that pizza chart. We also have the private service providers. FUNASA is the one that has the largest coverage. Now, the citizens can use private service providers from time to time. As an exception, when the private system is not able to provide the service and the citizen has to go to the public sector, this is what happens, for example, when a child needs to be assisted at home. In such cases, the patient can go to the public healthcare network, and also there's an act that was created to protect a system. It works as a single insurance that can be used both in private and the public networks. Now, I will talk a little bit about the financing healthcare, and I'll briefly talk about it and talk about the difference of coverages existing. The public system is a system that includes 7% of the payment done by the employee plus a contribution by the state. This is administered by FUNASA, and it's related to the income of each citizen. So the citizens in this plan, they are generally low-income people, and they have 100% coverage here. It's important to say that primary care is also covered 100%, regardless of the income level. And the citizens over 65 are also covered 100%, regardless of their category. We also have a quality of free election, in which you can choose the private system or not. In the private system, you also pay 7% of your income plus a premium rate that is fixed by the health agreement. And the coverage will depend on the agreement that is made. So in addition to diagnostic treatment, you have 100% of payment done by the state and coverages of 100% as well. So we don't have payment for high-cost diagnostics here. So what do we cover? In 2004, healthcare reform separated healthcare assistance and public health care. Before that, it was pretty much mixed together. And what we did there is that we separated the assistance networks, primary care, hospital care, and we registered hospitals. So we had a lot of management audits, and we established high-performance management. We have hospitals with high complexity, which respect these coverages. This act is called the second act in the slide is related to the judicialization of medicine, and also there is a chapter related to sanitation as well. And you also have the rights of patients and the norms related to protection of patients' privates, access to patients' information, and so and so. We also have other things included there. The Act 2584 includes other systems that the previous law was unable to cover. As Sebastian said yesterday, this was the criteria for sanitation priorities, and it worked very well. Now, the prevalence of high-cost treatment diseases wouldn't be included in the law. So what we need to do is to have this law for high-cost treatment to seek a different way to prioritize, and then we could complement what we already had worked on. It's important to emphasize that high-cost treatments are incorporated in this law, but this was a way to prioritize their use. So in 2004, we had a quality reform that was broader. And here I must emphasize that the sanitation impact is not related to the ALRE program only, but the separation of functions enabled public health to do a lot of activities, such as the Chile Grows With You, which is a coverage of pregnant women, newborn. They are assisted all throughout childhood. So they receive, newborns receive their first layette, they receive a crib. There are also programs related to respiratory diseases, and many times these families are not under the conditions to face weather in the winter, for instance, and children will get sick. Now, you may have a child that needs a kidney transplant or something like this. This transplant can be covered, But if this child lives in a house that's not hygienic, the coverage will not happen because the child may be transplanted and suffer rejection. So it's all connected, and it's a different way to effectively see coverage of healthcare. Sebastian mentioned the general coverage system. We have about 80% of the diseases covered here, and we offer all the guarantees here. Sebastian talked about AURE here, and I will talk now about the financial protection system for high-cost treatment. So these include high-cost treatments, medication, medical devices, food that are all high-cost. We also were asked to talk about the public healthcare institutions. We have the ministry, the subsecretariats, the healthcare services, and the hospitals. We also have the primary care under the municipalities, which makes it difficult for us to coordinate. We have the autonomous entities such as FONASA, the Institute of Public Health, and we also have other entities. Judicialization is also something that I would finally like to talk about. I'd like to say that when the ALGE program was edited, so ensuring the right of healthcare to these people became a way of judicialization. For 10 years, we haven't had any lawsuits in terms of judicialization for non-compliance with the law. So all these provisions in the ALGE Act has not been translated into judicialization yet. This is very important when it comes to how the coverage is going to be treated and how the individual rights are going to remain being respected. As Sebastian mentioned yesterday, there is an increase in healthcare plans, which is a kind of judicialization that happens in the private system, and it's important in terms of price impact. We also have adverse effects, negative effects, which is related to medical responsibilities and complexity. Access to justice is a restraint to avoid the judicialization. When it comes to high-cost equipment, I'm sure that before the act was enforced, because we didn't have evaluation centers and technology, we had a prioritization tool. In the final considerations, I will talk about the relation between pharmaceutical industry, medical patients, and judicialization. So several resources for access to medications are financed by companies, and there's a scientific evidence shown in trials is not impartial. So when we join all this, when you have participatory systems, we are able to deliver better tools when we judicialize treatment or medications. So we have to be careful with courts of law. Not everything is real, and there's evidence that might show that certain medicine is not effective. It's something that's not going to be published, right? So we continue trying to improve on the acts and the law, the legislation that we already have. We have the Act of Access to Justice and Equality in Healthcare. This is a very relevant topic in Chile. When you observe the number of lawsuits between the private and the public systems, this is much more important in the private system than in the public one. So this is related to the lack of access on the part of access to justice for underprivileged people. Thank you very much.
Muito interessante, já começamos bem e também por respeitar o tempo. Então, sem mais demora, gostaria de introduzir e apresentar o Dr. Rodrigo Salinas, que continuará com a apresentação do Chile.
Muito obrigado. Bom dia a todos e todas. Eu agradeço por me convidar à Assembleia Legislativa de Minas Gerais e agradeço particularmente ao deputado Dr. Antônio Jorge e ao desembargador Dr. Renato Luiz por sua generosa hospitalidade. Eu peço desculpas por não dar minha palestra em idioma local, meu portunhol é muito ruim. Eu prefiro dar minha palestra em espanhol, propriamente tal, ou em chileno, mais bem, que é quase espanhol. Mi presentación descansa fuertemente en lo que ayer fue presentado por Sebastián Pavlovich y en lo que acaba de ser presentado por Andrea. De manera que me voy a centrar más bien en los desafíos que tiene por delante la reforma del sistema de salud chileno para intentar alcanzar la integralidad, y en particular la integralidad de las prestaciones asociadas a nuestra cobertura, que podemos decir con orgullo es prácticamente universal. A nuestra cobertura le faltan dos aspectos. Un aspecto es la solidaridad, que fue perdida en el tiempo de la dictadura militar, cuando los ricos pasaron a ser solidarios solo con los ricos, dejando a los pobres la posibilidad de ser solidarios entre ellos. Y en segundo lugar, la integralidad de la cobertura. Y me quiero referir en particular a los problemas que plantea el tratar de alcanzar la integralidad de la cobertura en un sistema globalizado donde las prestaciones de salud crecen diariamente a un ritmo vertiginoso. Este cubo fue presentado ayer por Sebastián y es un cubo que fue ideado a partir de información previa por la Organización Mundial de la Salud y presentado en sus 2 informes de la presente década. Y lo que quiere graficar es que un sistema universal con cobertura integral debe crecer en 3 dimensiones. Una dimensión es cubrir a todos aquellos que actualmente no están cubiertos. Y esa dimensión no es difícil de negociarla con la población, porque la población entiende que a medida que va creciendo la cobertura, va creciendo de modo homogéneo y no afecta selectivamente a distintas personas. Una distinta dimensión de crecimiento es la dimensión de reducir el gasto de bolsillo de las personas, disminuyendo lo que nosotros llamamos copago y la parte del dinero de salud que debe gastar la familia de su propio presupuesto. Y esto tampoco es difícil negociarlo con la población, porque se entiende que a medida que hay más recursos, se puede ir disminuyendo el copago de modo también homogéneo, favoreciendo a los más necesitados. Sin embargo, la tercera dimensión es la más compleja, que es la compleja decisión de ver cómo uno llena la dimensión de cuáles son los servicios que son cubiertos. ¿Y por qué es tan compleja esta decisión? Porque aquí es imposible avanzar de modo homogéneo. Acá cualquier avance significa dejar gente adentro de la cobertura y dejar gente afuera. Y esa es una decisión que de todas las que se toman en el modo de alcanzar cobertura universal es la dimensión más compleja, porque es una decisión política y ética, como dijo ayer Antonio Giorgia. Esto ha sido apuntado por distintos autores, pero yo creo que nadie lo representa mejor que esta profesora de salud pública de la Universidad de Harvard, Sofía Gruskin, quien resume en este artículo del siguiente modo el dilema al que uno se enfrenta a medida que va avanzando en la integralidad de la cobertura. Dice Gruskin, la mayoría de la gente responsable en establecer prioridades en salud tiene considerable capacidad en aquello que es relevante para decidir cómo usar los recursos de modo efectivo y los tipos de mejoras que deben enfatizarse. La mayoría también está preocupada con distribuir estas mejoras de modo equitativo. Concordante con ello, a menudo se invocan derechos humanos o principios de justicia distributiva para dar legitimidad a elecciones que crean ganadores y perdedores. Y este es el problema central, porque a medida que uno va avanzando en la integralidad y va transparentando que existe esta brecha, se hace evidente a medida que se avanza en integralidad que hay gente que va quedando cubierta y gente que aún persiste en la brecha. Y eso es lo difícil de argumentar y de defender política y éticamente, pero que es inevitable en las condiciones que hoy día se desempeñan los sistemas de salud. Por eso que me pareció tan acertado el título escogido para esta reunión, porque dice cobertura universal e integralidad posible. Nosotros en nuestro país nunca nos hemos atrevido a decirlo tan directamente. Nosotros usamos la expresión priorizar, pero siempre escondemos que esta priorización dentro de lo posible deja a alguien fuera. La cobertura tiene que ser universal, pero la integralidad en las condiciones de hoy día es una integralidad posible. Y esta priorización tiene, por supuesto, un lado feo. Y ese lado feo es el que representa que toda priorización significa también un racionamiento. Un racionamiento que para que la gente lo acepte debe ser un racionamiento que sea basado en una discusión pública, que sea transparente y además que cuente con un fundamento científico sólido, que permita decir cómo uno va priorizando y por consiguiente cómo va racionando. Y este quizás es uno de los principales desafíos que en nuestro país significó una traba, como se expresó ayer y se ha expresado hoy día, al inicio de la ley, por la oposición que el Colegio Médico hizo. Y la oposición que el Colegio Médico hizo a la reforma se centraba en el tema del racionamiento. Decía, aquí no hay cobertura universal porque no se cubre el cáncer de estómago, por ejemplo. Pero claro, ese no era que no hubiera cobertura universal, lo que no había era integralidad. Pero con fondos limitados, la integralidad total es imposible. Por eso que es tan acertado hablar de integralidad posible. ¿A qué nos enfrentamos? A que la justicia no tenga presente esta imposibilidad de integralidad desde un inicio. Y tenemos fallos en Chile, por ejemplo, como este, que dice que el derecho a la vida es indivisible, por lo que no resulta posible concebir que se pueda escoger para el otorgamiento de los remedios entre aquellos que tienen una mayor posibilidad de éxito con el tratamiento y los que tienen menores posibilidades. O sea, excluye la eficacia y efectividad, y para qué decir la eficiencia, del proceso de priorización. Y dice finalmente, los esfuerzos para proteger la vida deben ser lo óptimo de lo posible. Sin embargo, esta última frase del juez tiene dos lecturas. tiene primero una lectura que dice que debe ser todo, pero tiene esta última palabra que se engarza con el título de esta reunión. Tiene que ser lo óptimo de lo posible. Y quizá ese es el desafío ético que nosotros tenemos de definir de modo transparente qué es lo posible. ¿Cuál es el siguiente desafío para definir lo posible? Que el sueño de pensar que la ciencia por sí sola nos va a dar la respuesta es también una ilusión, porque la ciencia es un laberinto de información que cuesta desenredar. Es un laberinto que no es fácil de transitar respecto a comparar intervenciones entre distintos pacientes con distintas enfermedades y cómo priorizar uno sobre otro, cómo legitimizar a aquel que gana con respecto a aquel que pierde. Por eso que el tema del análisis de la información es clave para cualquier sistema que quiera establecer un sistema de priorización que sea aceptado y tomado como propio por la población. Existen numerosas iniciativas que ayudan en eso. Una, sin duda, es la colaboración Cochrane. Existe en Brasil un centro de la colaboración Cochrane. Hay redes universales. Todos los países que quieran establecer un sistema de priorización racional deben contar con una unidad de evaluación de tecnologías sanitarias. Nuestro país tardíamente la adoptó. Este gobierno, el actual, creó a partir de su mandato y ya en los últimos 2 años una unidad de evaluación de tecnologías sanitarias que abarca desde las perspectivas sociales hasta las económicas para definir cuáles son las prioridades que van a ser escogidas. Hasta este momento la unidad aún es pequeña, pero una unidad de evaluación de tecnologías sanitarias crece a partir de su conexión con el exterior, con el mundo. De manera que aquí nosotros como país hemos colocado un esfuerzo para que esto crezca y ayude en este desafío. Otro desafío.
Chile is making an extra effort for this to happen. There are some frequent diseases. We have a system that prioritizes some types of diseases, and this type of system will inevitably leave out those who suffer from infrequent diseases. So overall, we are going to prioritize diabetes, high blood pressure, heart diseases, which are more common. This happened in Chile. But those who have infrequent disease, when you have a prioritization system, you have the first criteria would be the frequency of disease. This person will always be losing. So we have approached this problem from bottom down, bottom top to Chile. So we try to address the problems of patients who suffer from infrequent diseases. Many times they have medications that are very, very expensive. So we created the Ricardo Souza Act to address these people. But the gap keeps on growing. It's a paradox between a caius and a turtle. The further we go, we are never going to reach this turtle that runs like a very fast bird. So in this graph here that was published 2 years ago, we see the increase in prices of cancer medication. And we have values that are unthinkable when you consider the norms of the previous medication that I showed. So Eclis Humanus is a medication that was approved for night paralysis. and it's been approved for other diseases too. It costs something to the tune of $500,000 a year. So this is something that tells us that the global system for investigation and development of medication is a very sick system. We don't have to think about paying for this. We have to think about how to intervene in a system that allows for this kind of cost. So the Act 2850 tries to address this challenge. However, we have other challenges that Andrea mentioned, which related to the conflict of interests. We have a generation of medications, and we have an effort to incorporate them in a list to make them available to the public. But there are interests that are secondary. There are interests of the big pharma industry and of other industries as well. So that's why in the laws that we have developed throughout the past years, we try to address specific provisions to avoid this conflict, such as was the case of Lei Ricardo Soto, the Act. If you are in the commission for this law, you can't receive presents, you can't have shares in the pharma industry 4 months before and after the law is voted, so that you have regulatory agencies, regulated companies, that you have a big turnout of people. Sometimes they're working in one place, in another place, and this cannot happen. This happens a lot in Chile, and through this law, it can happen. In the American system, for instance, all the money that is transferred by industry to physicians and the companies that they can't have these people in their personnel. This is a challenge, and for me, it's the most relevant one, considering the political and the ethical aspects, but also the challenges that are behind this. Thank you very much. Thank you very much, Mr. Salinas. That was an excellent presentation. Dr. Rodrigo talked about the conflict of interest. If Dr. Jorge allows me, for some lack of modesty, Dr. Jorge, he presented 3 bills to try to face the problem of the conflict of interests. This is a very important initiative in Brazil. And here in the state of Minas Gerais, we are in the forefront of trying to face this challenge. So now I would like to call Dr. Sofia Charvel, who's going to make the presentation about Mexico. Thank you very much. I'd like to thank the ILMG for the invitation, and I'd like to show my consideration for Roberto as well. I'm very happy to be in this country with such great hospitality, and people are very nice here with me. So I'd like to say that after the presentations in Chile, you gave me a hard job. They did it in a very good way. And so I'm going to try to start my presentation here. So when I finish, I will present some aspects, and then Mr. Fernando is going to be complementing my presentation. Well, thank you very much. In Mexico, the right to healthcare is is included in many different norms. On the one side, that it's different from what was done in Chile with the pyramid. In Chile you have the Constitution, international treaties. In Mexico, the norm will say the treaties, considering the reform of 2011, and they comply with the Constitution completely. So we acknowledge the international treaties in the same level as the Constitution. So we have Articles 1 and 4 of the Constitution, and we acknowledge the international treatments and the General Healthcare Act, which complies with many international treaties, such as the Charter of the WHO. It's important that we go further. We also have to consider the definitions and the criteria given by courts and appellative courts in regard to justice, and also the Supreme Court. In Mexico, this is something that is happening right now. We're establishing that healthcare financial resources needs to guarantee a minimum level of survival to women so that health quality of life won't be reduced. So whatever the trials establish that there are criteria that are attached to financing. So many of these resolutions in lower courts are contradictory to the criteria that are being used by the Supreme Court. This happens when it comes to cost, and some ethical and legal aspects are left aside. So the right to health, when it comes to the legislation way, it includes the protection of everything that state can realize to ensure the highest level of physical and mental health. So in practice, this definition here gives the legal basis for plaintiffs. So we have a broad protection. We have trials that consider this definition as a starting point, but it's a general starting point, but we also find the contradictions and in what this coverage for the right to healthcare is including. So in addition to the Constitution and the international treaties, we established that all people have the right to health care based on the first article of the Constitution that states that according to international treaties, we're going to talk about coverage for all. The law says that all people have the right to have access to a public service provider. So this is something that generates inequality, and this is very important. In Mexico, we have the healthcare issues related to work conditions. So if you are a state employee, the coverage is pretty much absolute, 100%. Now, some courts say that it's even more than that. You have to provide medication if it's not in the list of medications covered. Now, all the people that are in the popular insurance, healthcare insurance, which is more recent, they have a limited coverage. And this generates important imbalance, and I believe this is our biggest challenge as a country. For us, because of this, our General Healthcare Act establishes a bare minimum, regardless of your job. And it states that you have to have equality in basic service such as vaccination, primary care, healing activities. And this has to be on an equality basis for all people. And we have a basic healthcare catalog that is also applied. When it comes to universal access and coverage, this is related to what I mentioned before. There's a big difference in the access to the service providers. The general population needs to be guided by the criteria of universalization, of universal and comprehensive care. Now, some of these criteria is related to distribution, the region where people are located, and universal health care. Of course, these are complex themes which the country has not yet debated. The first one would be the ceiling for coverage, and we are very far from solving this. In the popular healthcare insurance, we established that a heart attack is covered up to 60 years of age in men and women. So this is a double inequality, because if you are 61, you're not covered. So why are you covered until you're 60? And women are much more likely to have heart attacks after the age of 60. So it's pretty much equals to say that women are not covered at all. And other diseases such as lung cancer, we have some inequalities which we can talk about later. So let's first talk about the decision, this shameful aspect of the popular healthcare system here. We observe that we have different types of litigation, and we're starting to have a structural litigation that impacts our budget, and others that impact other aspects of the economic. We are going to focus on the structural litigation because after the constitutional reform of 2011, we had some aspects that need to be dealt with. We had a protection to human rights. We only reached that in 2013. So these mechanisms are very young. So if we had judicialization litigation before the reform, it was very hard for them to reach the Supreme Court. It was truly hard for the decision to be related to the protection of healthcare, because it used to be seen as a social right. So after the constitutional reform, we had political basis, and healthcare became a constitutional right. So if we can see that we have seen some change, not only for the population, but also we see a shift in those judging this kind of litigation. So in Mexico, we have some phenomena that account for this judicialization. And right now, after the reform, we can characterize these matters. We have some main cases here that have been brought to the foreground. in the case of Chile, for example, you have super expensive medication, and what happened was the following. The national healthcare system were asking that the medication would be provided to the citizen, and this medication was not in the list of the catalog of medication that is provided to the citizens. Then lawsuits were brought. Of course, there's a conflict of interest there with the pharmaceutical industries and the judiciary. So I believe that in the decision given by court in this kind of this medication, it's called Solides, is something that was shady for me, in my opinion. We don't know what the real intentions were. The procedure of how medication is going to be handed over to patients is pretty much, and the court did find mistakes in the prioritization system. But if there are mistakes, we have to have a committee to determine whether the medicine is to be delivered or not. This is something very complicated because the committee is in the institution and it's made by doctors that work in the institution. So there are lots of conflicts of interests there. So the court didn't perceive or didn't want to delve into that, and they didn't want to deal with how this right was being delivered to citizens. Another important topic is that HIV patients treated in the Mexican Institute of Diseases, which is the most important treatment center for HIV patients, is something that demands the creation of a building, the construction of a building in the institute for these patients. So the HIV patients, they wanted to be assisted in a different building. So they are a very organized group and they come strong. And when they demand an action on the part of the institute, the Supreme Court decisions is in their favor, and this is solved in a different way. So what they said is whether you have an institute that will provide the right to health care, and they will include these patients. International recommendations say that HIV patients should not be isolated, and that's exactly what they were requiring. So if you cannot build a new building, you have to remodel or refurbish a new pavilion that you had so that you can improve the treatment. And this ensures a lot of financial resources for the refurbishment of this existing building. And of course, there was also a lot of lobby. And when you have a lot of demand on this treatment, so how can you delegate to a private hospital this care? So the institute fought a lot for this, and the more they fought for this, the less they'll be able to treat patients with lung cancer, for instance, with other diseases. So the level of discussion in this topic was not satisfying for the institute, and we perceive that there's no legal framework to address that in Mexico. So some judges will decide based on the Healthcare Protection Act. Others will consider other legislation. Some judges will, some lawsuits will not pass the lower courts or anything like that. Another important thing here is the budgetary impact. So to speak of an important budgetary impact, you also have impact in the budget. Of course, we have the numbers, but in the case of the Soliris medication, the solution was not what we thought would be right. So attention to healthcare policies. We believe that the executive branch of government cannot adopt all some kinds of policies, such as universal coverage, because this leads to inequality. In the last budget approved in November for the fiscal year of 2017, we had some cuts of social policies in the country. However, in the health sector, there was an increase in tax to provide for this sector. So how can we talk about universal coverage if we have so many cuts in the budget for health? So we think this is quite important. There are some cases that are going to help us understand the definition of public healthcare products. This, for instance, was the case of the legalization of cannabis, of electronics, cigarettes, and everything. So these are matters in which the courts are deciding on, and this explains why some matters in the healthcare sector take so long to evolve. We believe that the popular healthcare insurance that was created in 2013 is something that we have to be proud of. People didn't have anything, and they have a small coverage now. Of course, we have to advance in their rights. So this is not the only healthcare action that we have, but it's something to be proud of. We have the food that's given to children in schools, fighting obesity and everything. We have other aspects. What we're trying to reach is some kind of comprehensiveness so that people can see the public policies in a positive way. I've mentioned reform and human rights, and we are going to talk about what this reform can do in the Mexican system and the important impacts that this will bring to the healthcare sector. I certainly believe that, and we are convinced that the most important part is to try to have clear and transparent prioritization processes with popular participation, and of course that we have to have part of the budget to reduce inequalities. Also, some studies that we made reached the conclusion that courts are not to decide in many cases how this prioritization is going to happen, because courts many times don't know how this needs to be prioritized. Now, granting the decision for the purchase of a certain medication that is needed is something that they do have to do, but we have to include a good prioritization system. In Mexico, we had some interesting cases, for example, in communicating with the company about the Zika virus. Of course, we don't like contamination, but there's no information being given to the population as if the Zika virus was not there. This also happened with influenza last year, and there were many deaths, more than they should have had. And this happened because we didn't have any prevention. We decided to approve the dengue fever vaccination. We considered that for the Mexican dengue fever, we considered that the approval for this vaccination was premature, and the cost can be very high for that. So all these matters that generate conflicts of interest that go against international recommendations are some things that we face every day. And it seems to us that there's not much we can do to prevent these problems. So we think the most important thing is to have a transparent situation, to have clear mechanisms that can analyze the processes from very early stages up to the highest levels. So this is my presentation. I will hand the floor over to my other colleague. Thank you very much.
A la presentación del doctor Mauricio Hernández Ávila, quien les manda evidentemente un fuerte saludo. Le hubiera encantado estar aquí, pero fue imposible para él estar aquí. Pero creo que ya me la quitaron. A ver, ahí. Okay. Simplemente algunos datos sobre el sistema.
So continuing, we have some data on the healthcare system. This is the description of the organization of the systems. I have a couple of slides, so it's going to take me about 3 minutes. In Mexico, the access to healthcare institutions is governed by the income of citizens, pretty much. We have healthcare services. We have the classification of service providers that can vary as follows. You have public services for the population in general. You have services related to the rights, such as the lean plan, and a private sector, and others. This is a table of how many people are in the Alien's plan, others who have the popular healthcare insurance, and here we have the overall population of Mexico. And these numbers are regarding 2013. These are the latest data that we have. This shows us the magnitude of our service providers here. So this is some of the data that we have of Mexicans that are uncovered. We have many of our inhabitants that they resist. They don't want to have any kind of coverage. Some do not have any kind of coverage, and some of them have a double coverage. So if you have a medication for HIV patients, it's better in the popular insurance, I will use that. But I actually am a user of the private insurance. This will bring costs that are unplanned for the state. So 72% of the population has public coverage and receives assistance in public institutions and by different service providers. This is established in this small graph here. I'd like to say that the financing of Social Security institutions comes from 3 different sources: government funds, employers' funds, and the payments made by employees themselves. And this includes the popular service. The popular service is under the federal government.
So health service they provide health service for its members, and including primary health care and specialties. Both the state secretariats and the state health systems receive funds from federal government and state government, and there's a very small contribution that is done by users, either because they don't have popular insurance or because there's a certain condition, a certain disease that's not covered by the popular insurance. The private sector project is going to be funded, obviously, by users' payments and with premiums coming from sales of private insurance. So what we have is a highly complex system because of the way it is divided. Sometimes we have a double insurance, and sometimes we find people with no insurance whatsoever. And the same thing happens in terms of coverage. Coverage funding is completely different, and this is an important trigger for judicialization and the right to health. Those who are covered by popular insurance according to international parameters and the acquired law, well, those people could eventually go more to court. Thank you very much.
Muito obrigado, doutora Sofia.
Thank you very much. I have an announcement to make. If you have any questions, to any one of the speakers, please send them in writing to the members of the organizing committee so that we can start organizing these questions for the Q&A session, for our debate. I would like to introduce now Dr. Marisa Eisenberg from Argentina, who is going to deliver his talk on the topic rights to health in Argentina.
Buenos días a todos. Antonio.
Good morning to all of you, Antonio, Renato, Roberto. It is a great pleasure to share these days here with you, to learn, to share experiences. I'm going to be very brief. I'm going to talk about the civil code, the Argentinian civil code, but I'm not going to describe it into many details. We've just heard, we have a presentation of the Argentinian health system, and I'd like to invite you to take a walk with me through the system. It's a very complex system. There's a maze to go through. And we'll have to go through this maze, keeping in mind the goals and the function of a healthcare system according to its values, its needs, its resources, assuring access to healthcare services, quality, and efficiency. We have to improve our healthcare system. We have to be protected from financial risk. We have to provide quality services to the population with equity and efficiency. I'd like to thank the previous speakers, and I will make my presentation shorter because I will not repeat a few things that have already been mentioned. Yesterday, Antonio drew our attention upon some factors that interfere with the health level of the population, determining factors or determinants. And we have to keep in mind that an inclusive healthcare system means to foster macro policies, healthy macro policies. We have to improve life conditions, work conditions, the quality of life of the population. We have to improve what we have in terms of social cohesion. We have to have effective participation. We have to have a good environment, keeping in mind that it's important to have habit and behavioral changes. We have to have social equality. We have to develop new types of organization and new health practices. We take care of, I like very much this definition here, and I want to share it with you. Health is a social, economic, and political issue, and it's a fundamental human right. And this is the most important part of the definition. Inequality, poverty, exploitation, violence, and injustice are the root causes of poor health, of an inefficient healthcare system. The Argentinian healthcare system is organized according to the type of government that we have. Our country was born from the organization of prior provinces. They comprised the national state, but healthcare services were not entitled to or the task of the national government. So the first problem Argentina faces is its legislature fragmentation. We need to, in order to be fully operational in 24 jurisdictions of the country, we need approval or authorization from different agencies. The Ministry of Health is the one which makes decisions in terms of funding, allocation of resources, international and national actions, and there is a higher level of decentralization in the different municipalities, which also receive resources allocated to the primary health care system. Besides the state, in this maze that we saw in the beginning, besides the public subsystem of universal coverage for all citizens or all people that are in Argentina, when I'm talking about people that are in Argentina, I'm not talking about Argentinian citizens. The coverage is extended to everyone who is in Argentina. So free universal health coverage, along with a social security system that is organized based on formal employer contributions. There are also different types of informal jobs in the country. I was telling you that this is a maze, and you may be questioning yourselves, well, how can you have cohesion? How can you have a good articulation among the different activities of a subsector of Social Security that has 300 different activities, 24 assistant works, provincial assistant works, and also some deregulated social services under different legislation. Other works, other institutions, the army, and the legislature power, the legal power, also interfere. And the third subsystem, the companies. We have 5 million Argentinians, and the Social Security subsystem provides services to 40 or 50% of the population with formal jobs and their families. And the prepaid medical system has been recently regulated. Despite of the many years it's been working, it's been operational, it's been recently regulated, and it is connected to people that have the financial power to pay for it, which accounts for 8 to 10% of the population. We have different corporations, like you can see here, commercial societies, cooperatives, civil associations, foundations, etc. But the prepaid services do not cover only 8% of the population. They have the possibility of covering more people with partnerships with social works that are agents of their own systems, their own prepaid medical systems. So we begin to have a mix between the functions of the different agencies. From the standpoint of financial resources, we may say that the public system is funded by the national treasury, and the Social Security is funded with contributions from private employers, and the private is paid by users themselves. And what is the consequence of this? A fragmentation and a segmentation inwards of the health system in Argentina. because of the federal features and the features related to its segmentation. We have a high degree of normative dispersion. We have a high degree of inflation. The same segmentation that we see in the health system happens also when we look at the different rules that are applied to the healthcare system. So our system is a very complex system. It's not well articulated, and the consequence, the system tends to generate inequality because we have the two systems or different hospitals living together in the country, and people are covered by different systems. National social works are forced to provide a coverage plan that is included in the mandatory medical program, according to a resolution issued by the Ministry of Health and now coordinated by the Superintendents of Health Services. However, it cannot find mechanisms to quickly incorporate new coverages. Because of that, right now, the National Congress is discussing a bill to create a program to assess and validate health technologies. And a national act also forces private companies to comply with this mandatory medical program. And the discussion now is this program the minimum amount or the maximum amount? Well, this should be interpreted by the citizens, but obviously, the citizens say it's the minimum amount. The companies say it's the maximum amount. The mandatory medical service is it the only thing that they have to provide? No, all this. Well, the Congress, the Argentinian Congress, is compulsive and issuing acts for disability coverage, mental health coverage, HIV, generic medication, sexual health, reproductive health, oviduct, ligature, vasectomy, alcohol, hypoacusia. And let me tell you something that happened to us. Regarding the celiac disease, we acknowledged the problem, and there was an act issued incorporating celiac disease. Why? To help people with celiac disease, to help them buy special flours, special food. But now that the celiac disease is incorporated to the mandatory health program, the companies are now saying, well, no, but you're declaring a pre-existent disease. Therefore, we're going to give you 400 pesos to buy the flour, but you're going to add 2,000 pesos to your monthly payment because you are not a healthy person. You have a pre-existing disease. So this problem of acknowledging and incorporating new diseases has to be assessed not only from the financial perspective in terms of the coverage of the system, but to see how much it helps in terms of the population health. As you may notice, there is a dominant issue in the Argentinian public health system that has to do with the complexity of the health system and the complexity of the regulation framework. And this fragmentation has a paradox. Argentina is a country with important problems of access to health services for certain sectors of the population. But at the same time, in Argentina, there is an oversupply of human resources, installed capacity, and technology. And 50% of the technology in Argentina is located in a radius of 60 kilometers around Buenos Aires city. And this fragmentation with oversupply and social exclusion is a summary of the features of our system, claiming for a new map in terms of our commitments to the health system. the normative architecture of the right to health. We have been living this constitutionalization process in terms of right to health, and the constitutionalization of this right was an attempt to reduce the complexity of the system, because we thought, well, maybe by incorporating this right in the Constitution, we will be meeting a social demand. But what happened? Well, the results were completely opposite to what we expected. When we really inserted this right to health in the Constitution, the complexity increased, because when the right was inserted in the Constitution, the citizens now are facing a number of derivative rights that are difficult to limit and are difficult to manage. Take a look here. The constitutionality control in Argentina can be performed by any court, and as of the 1994 reform, and the same thing happened. The same thing Sophie explained happened when the human rights were incorporated at a constitutional level. Well, the right to health also was incorporated, even though it was not fully or expressively described in a constitutional norm. And this constitutionality control becomes a conventionality control. Now we have to establish if the period of time for a certain service provision is, it complies with what it is in the Constitution, and what human rights treaty won't acknowledge the rights to health. Well, the conflicts are scaling up, and we have the perfect storm. This is the cover page of one of our newspapers, Judicialization of Health. And this process had a first phase which was positive, because problems that were hidden gain visibility. However, the judicialization of health shows a medicalized conception and hides the hospital aspects of it, technology aspects of it. It centers itself in the biology of health, and it's full of conflicts of interest, because along with technification, life expectancy grows, overall survival rates grow for some diseases, and the new demographic and epidemiological map affects the entire population today. In some households, we have 5 generations of people living together, and the life expectancy that is now 75 years of age is still increasing. So we have new issues arising. We have to give new answers to new problems. I will close with this slide. What are the challenges? Of course, reduction of inequality and exclusion. This is the utmost challenge. In the short to mid-term, we don't believe that the formal work environment will have its own mechanism of social protection. So I have to think about a social pact that will allow us to universalize the health services, not only in terms of coverage, but also in terms of quality. The phenomenon that is linked to an increased consumption is something that I'd like to highlight here. We have higher demand for energy, higher industrialization, and products must receive proper finishing processes. And this has an impact in terms of the health system, because there's an impact in terms of the diseases. We have to focus our efforts on assessing the new health problems. And here I'd like to add something. The universities are important players in this process. Through the so-called recontextualization, reality recontextualization laboratories. In these labs, we can sort of measure the possible impacts, and we can assess corrective actions before the impacts are generated. These are the new paradigms that are claiming for more room in terms of rights to health. We have to work in the health sector to improve health, because this small world is our home, It is the home of all of us global citizens. And we suffer from diseases that are caused by viruses and bacteria that no longer respect borders. Men and women cannot be a part of these new dimensions because the power of laws and the power of the way they are interpreted is very important. And in order to follow the social and economic transformation, they must be capable of taking the steps towards this new health service, this new health system that is focused on citizens' rights. Thank you very much. Thank you, Dr. Marisa. We will now listen to Dr. Raúl Alejandro Ramos. Raúl, you have the floor. Thank you. Good morning to all of you. First of all, I'd like to thank the state legislature, the Ministry of Health, Roberto and his entire team at the World Bank for allowing me to be here, for giving me this opportunity to show you what we are trying to do at the Argentinian Ministry of Health. It is the first time that I have a chance of attending such a big event. I'm very happy for this opportunity. I feel very excited about it. And before the other sessions began, I found this meeting very, even before I heard the different presentations, I realized that this event was going to be very productive because just by talking to some colleagues from different countries, we were able to get to very productive conclusions. So I really understood that this event could provide me a lot of important information on these issues. Well, I could say thank you to all of you because I could start just by saying thank you because everything has been said. There's not much for me left to say. It's a systemic transversal problem that reaches all of us. But very rapidly, I'm going to show to you what we are trying to do at the Health Ministry of Argentina. I'm going to start with some definitions issued by the World Health Organization in terms of rights to health. The WHO Constitution says that it is to enjoy the maximum health that one may have. This is a fundamental right of all human beings, and the right to health includes timely access, acceptable and equitable access to healthcare services. Good quality healthcare services. It is related to human dignity, and it is a universal right. In Argentina, the right to health is part of our national constitution issued in 1994. And at that time, we incorporated 11 declarations and human rights treaties that can be seen in Article 75 and Size 22 of our national constitution. The international right, including human rights, must assure a healthcare system that allows or that provides access to primary health care services. This was mentioned in 1978 when the Alma Ata was defined. Despite of all this, millions of people all over the world are still living under the poverty. The poverty limits every day, and we still, because of the minimum health expenditures everywhere, millions of people do not have access to comprehensive health systems to prevent disease. They do not receive health services when they are ill, and they do not receive palliative care at the terminal phase of their diseases, as it is mentioned in the Pan American Health Organization. And here we see the diagnosis of the situation. We see a vicious cycle. We have here an inadequate health coverage that generates a social cost that incites mostly on vulnerable groups. It leads to an increase in the expenditures and income losses, and it leads again to lack of universality. So this circle leads to disease and poverty in the families. Like Marisa explained very well, by the way, one of the main problems of our country is the segmentation and fragmentation that we have, which leads to inequality and inefficiency, harming universal access or impairing the universal access, quality, and funding of health. And we have lack of regulatory capacity, verticality in public health programs, and an absence of a service provision network, health service provision network. What can we do? Well, we understand that universal health coverage is inadequate approach if we want to foster the right to health. The Ministry of Health in Argentina complies to all these principles, and within this context has created a health plan according to the current situation we live in our country, a situation of crisis. And we believe that we're going to have, with this plan, a feasible and desirable health system. According to what has been said in the previous presentations, the idea is that the new health plan covers every single Argentinian citizen. Within this context, well, the current minister, based on the new government management, has established 12 policies within the national health plan that are going to be implemented in the coming 4 years. And among these policies, we see universal health coverage. Many other policies can be seen here. They have already been mentioned by the other speakers, such as the determinants, the assessment of health technologies, the integrated health networks. Well, all these policies were incorporated. I'm not going to detail each of them, but we can see that the health universal coverage is now part of the state policies. So under the role of the Ministry of Health, we are establishing dialogues, consensus, and strategic alliances. Our system is strongly dominated by union associations, different unions. So with these strategic alliances, and also based on socioeconomic and legal and political sustainability, we will try to reach health universal coverage, which now became or will become a state policy. The universal health coverage will force us to create partnerships between the federal government and the different provinces. Like Marisa said, our country is a federative country. Each province has its own autonomy. That's why we have to create partnerships with the different provinces, and we have to have a good articulation with international and national programs. We cannot have a pattern of users. We have to extend the coverage to the entire population. We have to strengthen the primary health care. We have to have a good primary health care strategy with access to medication, with a decreasing national support because of our federalism. And we also have to, and the universal clinical history is also a topic that's part of our focus. Each country must organize its health system and use its resources to assure access to health. Some basic concepts concept given by Dr. Maureen Birmingham from the Pan American Health Organization. Access is the capacity of using comprehensive health services, appropriate, timely, and good quality health services. Universal access means the absence of geographic, economic, social, cultural, organization, or gender barriers. Health covers the capacity of the system that the system should have to give and to respond to the population needs in terms of infrastructure, human health, and human resources, and health technology. Universal access and universal coverage are the basis of an equal or equitative health system, and we have to have a multi-sectorial focus to approach the different social determinants, such as Alon has been saying for a long time, fostering the commitment of the entire society with the goals of fostering health and welfare. We also have to unify funding in one single fund, eliminating direct payments. We have a problem, which is the fact that we have several funds instead of having one single health fund, and this leads to many problems. We have to expand the services to vulnerable groups. That means to generate interventions or implement actions that meet the unattended needs, such as maternal and child and children mortality, chronic diseases, HIV, tuberculosis, violence, urbanization, lack of drinking water, and environmental services. We have to reduce costs, moderating the use of medications, stimulating the consumption of generic drugs, not providing incentives to multiple appointments, aiming at having shorter hospitalization periods and guiding patients, orienting them to look for family physicians. We have different epidemiological patterns, so not all the responses should be the same. To each epidemiological demand, there must be a different health answer. We have to expand an equitative access to comprehensive health services. We have to strengthen governance. We have to increase and improve funding, and we have to strengthen the intersectorial coordination. We have to improve human resources planning, training, distribution, and quality of labor conditions. We have to have the right people with the right competences and the timely place and moment. That's what we believe would work. We have to improve the resolution capacity of health services, providing care according to people's needs, according to scientific and technological, current scientific and technological knowledge, to have health policies that will truly improve the health services. As a conclusion, well, very briefly, because I don't want to overshoot my time, health is a core component of human development. Universal access and universal coverage prevent impoverishment of individuals and are key elements if we want to assure a healthy life. Thank you very much to Brazil, Minas Gerais. Thank you, Belo, Horizonte. Thank you all.
Novamente, agradecendo aos nossos palestrantes por suas intervenções muito interessantes. Nós vamos fazer um pequeno intervalo de 15 minutos, e aí eu vou pedir um favor a vocês. Por questão de hora, eu gostaria de talvez pedir o impossível. Nós estamos aqui no um desafio enorme. O desafio enorme que nós temos diante de nós é conseguir fazer esse intervalo em 15 minutos. Esperamos estar de volta daqui a 15 minutos para começarmos as nossas discussões, os debates, que, como eu disse, é a parte mais importante desse dia, tá certo? Vamos discutir as 3 apresentações, ok? 15 minutos, estamos de volta. Muito obrigado.
Eu tô de cá. Você tá me escutando? Tô ouvindo. Eu não escuto. Ué.
Tá estourado aí?
Alô? Não, melhorou. Olá, tudo bom? Não tô ouvindo. Ué, tá ligado aqui. Tá ouvindo agora? Tava funcionando? Tá, agora parou de estourar o relé de vocês.
Eu testei antes, não dava. Aí agora que...
Essa cabine pequena, né? Também esse aqui é... Agora, ontem...
Você tem que ficar esperto com os laterais aqui. Nossa, porque cai tudo, viu?
Ontem, lá no Minascentro, eles estavam com uma das cabines novas. O vidro vai até lá no alto. Final,
cabine mesmo, né?
Nossa Senhora.
É, porque você tá dando equipe?
Gente, eu queria acabar com vocês duas. Era isso?
Nossa,
eu
tava muito
gritava tão
estourado.
alto. Tava assim,
Tava
tava
muito
forte
estourado.
demais.
Não, eu por fim, eu
the static and the radio with satellite and television. You can go anywhere. Miami, New Orleans, London, Belfast, and Berlin. And if you listen, I can call. And if you jump, you just make fall. And if you shout, I only hear you. If I could stay, then the night will give you hell. Stay, then the day will keep its trust. Stay with the demons you drown. Stay with the spirit of funk. Stay, and the night will be an Three o'clock in the morning, it's quiet and there's no one around, just the band and the clatter as an angel runs to ground. Just the band and the clatter as an angel hits the ground. If I could, yes I would. If I could, I would let it go. Surrender, dislocate. If I could through these lines Is it getting better? Or do you feel the same? Will it make it easier on you now? You got someone to blame. You say one love, one life. When it's one need in the night, one love, we get to share it. Leaves you, baby, if you don't give up. Did I disappoint you? Or leave a bad taste in your mouth? You act like you never had love, and you want me to go without. Well, it's too late tonight to drag the past out into the light. When one
Bom dia. Muito obrigado a todos pela colaboração. Retomando nossos trabalhos, eu gostaria dois avisos. Primeiro, obviamente, contamos com a presença.
First of all, we are going to resume our debate here. So I'd like to have you all here in the lectures that we are going to have this afternoon and also tomorrow in the morning. We are going to have 2 more panels today, and tomorrow we are going to have a general discussion trying to consolidate all the presentations and topics discussed here during these 2 days. So, once again, I was asked to remind you that the certificates of participation in this event will be available as of tomorrow morning. So you can come to the front desk and get your certificates tomorrow morning. So it's another motivation for you to be here tomorrow morning. So as the coordinator in this panel here, I would like to summarize, actually to make some considerations because before we start our debate. As you've seen in these 3 countries that come from north to south of South America, the challenges are very similar. And they are very similar to our challenges as well, to the ones that we have in Brazil. Now, even though the structures and how the healthcare systems are organized might be very different among these 3 countries that we've dealt with this morning, we have systems that are very different, but the problems have a nature that is pretty much the same. So that's why this debate and the learning about international experience is something that helps us all. So everyone here can learn with everyone, and we can try to learn positive lessons, learning what worked and what didn't work in each country. So once again, I congratulate those who organized this meeting for the initiative. So I'm going to start with the questions that are going to be made orally. We have 4 people that would like to ask questions orally, and many of you have made questions in writing. So let's start with the oral questions. So if you do have a question, please come to the mic. First person is Rogério Delamare from the Health Secretariat of the City of Belo Horizonte. The question is addressed to the whole panel. Good morning. So just as a reminder, please, your question should not last more than 2 minutes, and try to be straight to the point, please. Good morning, everyone. I have 3 things to say. First of all, congratulations for this meeting. I'm very happy to have had the opportunity to be here. I'm from the Healthcare Secretariat of Carlos Sagas. It's a small municipality. I'm the health secretary there. My mayor is also here, and he is a physician, and he's always urged that health reaches everyone. So based on that, we have to consider that our city, my city, is marked by inequality when it comes to public services. Recently, I saw a statement from governmental authorities saying that inequality is an interpretation similar to the interpretation of vanity. It simply doesn't exist. I have 10 claims daily regarding some level of complexity in terms of healthcare. When I meet these claims, I am helping inequality to help, because this person that made the claim somehow has access to the legal system. So in granting these claims, wouldn't we be helping perpetuate the inequality in healthcare systems? Thank you for your question. And as you mentioned, access to the legal system is something that has its own difficulties, and it generates more inequality, because we service only those who, first of all, have information. And second of all, we service those who have the education and the money to pay for legal fees to reach the legal system. So, of course, that the access to the legal system generates new inequalities when it comes to healthcare. Of course, that legal system is not to be blamed alone. We have to incorporate elements that help the legal system. Judges are alone to decide about these problems, for instance. So this kind of meeting has exactly this purpose, so that we can together find paths to help the legal system to be able to have more equalitarian access. Now, if you're asking me what my aspiration is, my dream is to have a court with health competencies, so a specific forum to understand the complexity of healthcare matters. So we, in that case, need to have expert judges in the area with teams that are able to solve these problems. Sorry, if we are not adding segmentation to another conflict to segmentation, which is the decision making on the part of the judiciary. Just to add to what's been said, lack of access to the legal system increases inequality in the access to healthcare. I'd like to talk about what happened in Chile regarding that. The first one is that the first one is the increase of private health plans in the country. What happens is that lawyers are trying to they are working on these cases. In this case, people don't have access to justice for free. So this has become a big legal industry that has been replicated all throughout the country. Another point is related to social movements. In Chile, the citizen empowerment through social movements has been very effective, much more than judicialization. And people urge that their treatment and their diseases are incorporated in the system, not individually based on a legal decision. Another difficulty when it comes to access to justice in my country is that attorneys that are experts in the healthcare area are very few. So educating lawyers that are specialized in healthcare is something that should be included in law careers. And this is also some things that we have to work on is to increase the circulation of information on access for the citizens in general. In respect to that, I would like to make a recommendation for those who are interested in this matter. There's a book by a Canadian author called Colin Floyd. That has a chapter called Judicialization is the white knight of the healthcare system. It talks about how careful you have to be with judicialization, because we run the risk that only the people who have the possibility to take their cases to court will have access to health care. Those who are unable to do that for any reason will be in a situation of a lot of inequality. So I believe that this is a very important reference, and it's a text that it's interesting for you to check on. The next question is by Mr. Marcos Fonseca from Hospital Cristiano Machado. The question is for Dr. Heisenberg. Good morning. Good morning, everyone. Well, actually, the question was partially answered, but this is a concern that I have. In practice, we see that there's a big industry of judicialization. So lawyers, people have specialized in making this happen. So we have lawyers involved in that and other professionals as well. So I keep asking myself, what can we do in addition to providing new legislation? So it's partially been answered, but I would like to comment more on that. I would like to make like a corporate defense here. I'm not sure if we, the lawyers, generated this industry. Before lawyers, there's a pen, someone using a pen that is prescribing something to an 87-year-old lady. So whoever is making this prescription of a certain medicine is also included in the problem. So be careful there. It seems to me that it's essential to work with citizenship policies. So as my colleague here in the panel has said, we need concrete actions. First of all, you need reform. We need programs for reform. So law schools in my country, in Buenos Aires, I teach a subject called healthcare law. And this is an undergraduate school. In graduate studies, we also have the same subject. So our mission there is not to talk about malpractice itself. Healthcare law, as an autonomous subject, has to build bridges in the legislation. We have to understand that the complexity of the healthcare system cannot be solved by one single physician. It can't be solved by a Nobel Prize winner in economics, and not even by a good lawyer. So healthcare systems have to be built with everyone jointly. And we have to start incorporating these ideas. So we have to have dialogues in our countries, and we have to include everyone, the medical community. So how can we discuss this and not have the medical community participate? So how can we expect that this law will actually become enforced? Another aspect that I think is also important, that's much related to this meeting here today, are the medical residence programs and provided by the government. In Buenos Aires, we incorporated the hospital lawyer and residency programs so that they are formed inside the hospital, and the doctors can consult this lawyer preventively. In Argentina, we've also incorporated bioethics as a normative, the assurance of laws and all medical directives. But we still have a long way to go. So we, lawyers, we can make a small step forward, but everybody has to be called to try to find an answer to this huge problem. Thank you very much for your question. So now we have a question for Dr. Sofia Schara. On one is from the National Social Security in South Korea. Obrigada pela sua apresentação maravilhosa, adorei a sua... o sistema de vocês é bastante diferente do meu, então eu gostaria de fazer uma pergunta. A primeira questão é, para ter uma sustentabilidade do seu sistema, você mencionou que muitos participantes, na verdade, mencionaram que a gente precisa entender o benefício do sistema de prioridades. Mas o problema é como fazer uma decisão desse tipo de cobertura para esses benefícios.
The judge made a decision about that, but I also impressed that judge is not the healthcare expert, so they didn't know the exact the expertise on healthcare field. So my question is how to provide the relative support to judge's decision, regard, or is there any? Some participants already mentioned the question, but how to educate the judge or lawyer to solve this kind of problem.
Thank you very much.
Muito obrigada pela sua pergunta. Eu acho que é uma pergunta muito importante.
I think that there's a lot of research in about what the role of the courts should be. And we think that the role of the courts should concentrate in analyzing the transparency of the procedimental part of the health sector. if the court starts to decide if a medicine or a treatment or an action should be given by the health system, then we really think we are in a big risk because they don't have the specialty. So we really think that if they constrain to do just analysis of the procedimental part of how, for example, the health sector is giving the prioritization, then everybody should have a specific role instead of trying to do the role of the other, because we are having problems in that, big problems. For example, with cannabis legalization, the court made a very, they sustained their answer in freedom and in a lot of things, but never taking care of health, as if it doesn't have any problem with health. So we really think that they should be aware of this.
As the coordinator here in this panel, I will add a question that has been sent in writing, and it's related to your question, so they complement one another. So it was made by Mr. Passos from the Self-Management Institutions Union. We can talk about judicialization without considering the criteria based in evidence. Isn't it a risk to health if you're taking decisions related to judicialization without considering that? And the second part of the question is very interesting, actually. In this case, if it's characterized that's been a legal or a medical error, who's to be held accountable? So this is a question for the panel. Personally, I say that the development of medicine and the system described for prioritization is a positivist system. But this doesn't mean that it's derogatory to other forms that are used in other countries. But the prioritization process that we have to make to achieve transparency and coherence in a country that have lane policies, so there is the state is setting aside all religious and supernatural aspects. So the state relies on science, and science in medicine relies on a positive method that has cycles of evolution. This way, a legal decision that considers scientific information to determine public expenditures, for example, if they don't consider science there, they will be committing a mistake. A question that is important in terms of judicialization is related to the conflict of interests. I mentioned that when I presented resource related to protection so that patients can obtain some kind of medicine. This comes from the industry sometimes. In our country, what happened is that often a patient has to be treated for something, and they ask this patient to seek coverage, but necessarily this patient wants to have coverage that is covered elsewhere in the world, but not in our country. So what happened is we noticed that medicine didn't have this relationship of cost and the impact of the medicine in a person's health. So there's no study in that regard. So we had other cases in which people requested for a medication. Of course, they were prescribed the medication by a doctor, and but these were not medications that were authorized necessarily in our country. So we have to know what scientific evidence that we have available, and judges have to analyze that. Now, there was another case, there was a discussion whether the day after pill was an abortion agent or not. It was a big debate, and we saw that what judges thought is that because for 15 years people had been saying that it was an abortive, it was, and there was no scientific evidence to that sense. So this shows that the assessment of scientific evidence needs expertise as well, and it is the proper analysis on the part of judges so that they can prescribe it or not for treatment.
Another contribution that we make suggest here to prevent judges from making decisions without scientific evidence is the creation, or is something that we are doing. We're creating a national agency to assess health technology and health devices, and the judges are therefore supported by the best possible scientific evidence. By doing that, we will prevent mistakes from happening. So I think that this health technology assessment or evaluation agency would be a way to prevent this problem from happening. One problem that we have in Argentina, the organization mechanism for clinical investigations, the IMAP Institute, works based on presumptions. One is that they authorize the possibility of using a medication whose effect is different from the approved effect, and the other is a compassionate use for those people that have no chances with other types of treatments of healing, even though the drug is not authorized in the country. Something that is going on in our country is that, well, some new elements are being now bound to the right to health. One is the Article 199 on clinical trials. This article established that it's mandatory for subjects that are enrolled in clinical trials. Well, if the laboratory decides to interrupt the manufacturing process or interrupts the manufacturing of the certain medication, those subjects enrolled in the trial must still receive the medication, even if it's out of the market. Another thing related to health technology as well, this is the point that is being very controversial, and the agency, according to executive project, established that the decisions are binding. And the Congress said that the binding decisions will not be approved, will not be passed. And last week, I attended a closed meeting happened only for judges in Argentina. The name of the event was Just Evidence-Based Justice. So maybe this is a way to go, or a way to question more. Well, in this regard, I would just like to say that the situation concerns me, and judges must be based on scientific evidence. They are not prepared to analyze, to assess make decisions based on the best scientific evidence. In Mexico, this was going on in different topics. I will get back to the topic of cannabis legalization. We had very important journals that provide scientific evidence, and they say that there are no negative effects related to consumption of cannabis. But other journals say that a sustained consumption, sustained intake of cannabis, etc., is such and such. But anyways, we are working with the best available scientific evidence, and we insist that judges must make their decisions based on scientific evidence, but above all, they have to focus on their task, interpretation of norms. If the experts say that there are no problems related to consumption of cannabis or marijuana, but if there are long-term problems, well, what are we going to do? When we have scientific evidence available, then we'll show it to them. And they are not scientifically skilled or to interpret that. So physicians, researchers, experts that are able to analyze the information available are the ones who should make decisions, and judges should not be able to make decisions related to granting or not granting in drugs or interpretation of scientific evidence. This is something very important that is going on in Mexico, and we want to prevent this situation from happening in there. We are facing now very important topics in some first instance courts. Sometimes we have patients who go to court saying, well, I need this drug, otherwise I'll have health problems. And judges are issuing injunctions forcing the drug to be delivered to these patients. The decision is sometimes made in one single hour. Judges don't even take time to assess the topic to see if the drug is indeed needed. So we have to discuss that in Mexico, and the issue of responsibility, whose responsibility it is also becoming worrisome there. Okay, we have another question here from Cláudio Ribeiro Figueiredo from the city government of Sete Lagoas, State of Minas Gerais, Health Secretariat of Sete Lagoas. Good morning. We in Latin America are living a phenomenon because the first healthcare experiences, the first healthcare services delivered to the population were done by the church. After that, with the rule of law, the state became responsible for supply or delivering healthcare services. I will speak on behalf of my city. We'll talk about the experience that I have in my city, what is going on there, and other cities in the state of Minas Gerais. The main challenge is to combine public equipment and the private networks and non-profit organizations, churches and other associations. First question: in your country, do these entities, non-profit organizations, have tax exemption like here in Brazil? They can provide or deliver health care services without participating in bids. So does it happen also in your country? And second thing, I'm a lawyer. I'm specialized in public law, and I learned in the academia that the public interest is dominant, and public assets. And in the recent days, the justice blocked $2 million, which is equivalent to the monthly payments that we have to make, and this money was blocked because of an injunction to pay the Santa Casa hospital, local hospital. They said that they needed to be paid, and so the bank accounts were blocked. We could not change that. In less than 48 hours afterwards, the money was withdrawn by the Santa Casa hospital. I'd like to know if this also happens in your countries. because of debts and payments to be made, can these entities get this type of legal decisions, legal sentences made? Because, well, I know that individuals were able to do that, but not service providers or institutions. And now we are facing many problems. The salary payment is more than 60 days late in my city because we have no money to pay. We have to pay because our bank account was blocked and the money was used by the Santa Casa Hospital because of this injunction issue. Well, in Chile, there's a complementarity between the public and the private world, and this complementarity is regulated. The public system may refer to the private system. There is a decree 36, that regulates what the private system may deliver, and public hospitals work as an extension of the public health system, and they have their own regulations. So in Chile, the Ministry of Health may make decisions related to private systems. We also have health care partnerships. For instance, during the winter, we have respiratory diseases, and they take up many hospital resources. So we have partnerships to use the private infrastructure. For instance, we have a deficit of beds in the public health system. The topic of churches and if there are health institutions that belong to the Catholic Church. Well, we have one, and it is included in Decree 36. Funding is not specific, but they are not entitled to any bed benefits or tax exemptions. This type of agreement must be bidden. There is a public purchasing system that must be complied with. The only exception is when we purchase services from other public hospitals or from the army. Everything else has to comply with the same rules, regardless of the institution. We don't have this problem in Chile because we have a specific funding, a specific budget for payments, for all our payments. Well, in Argentina, we have a similar scheme than Chile. We do have fiscal benefits, tax exemptions. Yes, but we have no benefits in terms of direct hiring, and actually it is forbidden. The bids are mandatory. These institutions do not have straight access. They have to comply with the rules. The church is not a direct health service provider. They don't have their own hospitals. There are, however, congregations that provide assistance to some private hospitals. There are some social works hire these hospitals, but this is outside the public system. The public system recently carried out a partnership with a religious organization, but not for the provision of healthcare services. But, we have a national hospital, the Posadas Hospital, and the agreement was to build a family house to host patient relatives, patients that will have, for instance, in terms of oncological patients, they live sometimes far away from the hospitals. They wouldn't be able to pay for transportation costs. So this hospital built a house, the Posadas house, and the house is being managed by a religious community. And the hospital pays for that, and the religious community manages it. But we don't have this modality or this category of religious institution providing health services to the state, to the government. An announcement. We have no more time for... Well, we have many questions to be answered, so we will not receive any other questions, just the ones that we have already here with us. State Representative Antônio Jorge, do you have a question? Well, I'd like to thank the different panelists for their brilliant talks and contributions, but my question is directed to Dr. Rodrigo Salinas. Yesterday, Dr. Sebastian met many of the, went to the state legislature, and many of had conversations with many of our friends here. And like you mentioned quite well, there's an ethical dimension that requires maturity from the society in terms of establishing priorities. There are winners and losers. I really like this term. And this ethical dimension in our reality here has been overcome by other problems. We are discussing the comprehensiveness issue within the context of comprehensive care and not based on what should be provided or not by the public government. There is no distinction of diseases to be covered by the Brazilian Unified Health System. I believe they have to be brave enough to learn from the Chilean experience. If indeed, the prioritization process, and well, I heard the data very quickly, so please, Dr. Rodrigo, correct me if I'm wrong, but considering the priorities, it sounds to me that the effectiveness of coverage is above 98 or 99%. This is a very a great piece of information, piece of data, because this is the beta we have in terms of comprehensiveness. We are ethical enough to say that no pathologist, no disease should be prioritized. All diseases are covered by the Unified Health System, but we are forced to acknowledge that our effectiveness in terms of coverage is much below 98% for many diseases. So differently from maximum, it's difficult to imagine that as of a certain age, because of gender, we will have no more coverage for a myocardium infection, for instance. Because of our ethical purposes, it's very difficult to understand that. But on the other hand, I can say very sincere, because I'm an activist and a former manager of the public health system, that our reality is a coverage of not more than 70 or 80% of all infections. So this is the discussion that requires, that demands a lot in terms of social pact, a lot of maturity to discuss. We are paying for our ethics, so to say, but we are not being effective in terms of the effectiveness of our coverage. And the prioritization proposal described by the Chilean speaker, well, it interests me very much. There's a certain dimension in terms of social pact, but they assure that the services are provided. Dr. Rodrigo, can you tell me if it is true that everything you mentioned has a 95% coverage or beyond that? And are the users? How do the users feel okay in terms of the Chilean coverage, health coverage? Is the state legislature program in Chile trusted by the population? Thank you very much for your question. Well, I personally believe that the comprehensiveness, that health comprehensiveness is a chimera. Just like I showed you during my presentation, it's just like the paradox of Achilles and the turtle. I mean, it doesn't matter how fast our comprehensiveness strategy advances, we will never be able to have 100% coverage because the demand grows every day in the world. Thanks to scientific research, well, we have to be thankful for that. But there's also an industrial interest that is behind the generation of new technologies, and nowadays we integrate research and development, and because of that, the comprehensiveness of the health services provided becomes a chimera, and we need this comprehensiveness in order to make things possible. And in terms of prioritization, well, the prioritization process will have wounds on the road. That's why the rationing topic is very critical from the ethical standpoint, because the losers must assume that they are losers in a system under development, a system that is going towards the greatest possible comprehensiveness, and they must understand that someday they will be able to have access to the services. But this is the most difficult part of it, establishing the priorities. And what is the problem in Chile? The problem in Chile is that, well, differently from Brazil, our healthcare system is not a solidary system. People don't feel it as a solidary system. We have a system that has been inherited from the military dictatorship. And well, most of the population depend on public health insurance. The poor and the rich parts of the population do not, well, they don't pay for the public insurance. They pay for private insurance. So the greatest threat in Chile is the fact that we have to rationalize the healthcare services provided, and this affects above all the poorer, the older, and those who have the worst diseases. And Antonio, you asked me about the measures that we base our prioritization process at the state legislature. Well, there are 4 factors: the health, or the disease burden. The higher the burden of the disease, the higher the priority. Secondly, the existence of effective measures, effective health services to fight the disease. So, if we have diseases that are high in terms of priority, and if interventions are effective, then the priority is going to be even higher. Thirdly, we must have the capacities in the country to give an effective response to all users homogeneously. So service provisions or treatments that are the capacity only in the capital of the country cannot become a priority, because there are other capacities that can be delivered to the entire population in geographical terms. Our territory, although not so big as the Brazilian territory, has some remote areas of difficult access. And we have to consider also the cost effectiveness whenever possible. I will repeat, whenever possible, we look at the cost effectiveness. So it is relative when compared to the other 3 factors. What is the problem with this prioritization process? First, it delivers more value to individuals with more prevalent disease. This is difficult to explain from the standpoint of human rights. Why should I have more access to health services? Well, just because my disease is a more prevalent disease, and the poor one who has a rarer disease will be in the waiting list forever. That's why we have a new act that approaches the problem of rare diseases. And the second problem is that to implement a prioritization process, health intelligence resources are needed to assess the effectiveness of the service provided, to assess the delivery of health services throughout the country, and to think about new technologies for the future. And this requires money. And in a health service, in the health service system, when there's no money for vaccines, it's difficult to have money available for technology assessment, intelligence, and other resources.
So there is a fund that needs to be set aside for that. We have prioritization criteria that are rational, but there are weak points considering the consolidation of human rights because we have to solve the aspects related to the values of society. The demands that we have now is to structure a solidarity system such as we had up as of 1981. I'd like to add something. I'd like to talk about the Ricardo Soto Act, which deals with some difficulties in this design, and it makes some alterations when it comes to prioritization. It addresses especially the citizen participation and the representatives of patient associations. So they help prioritize what needs to be included in the high cost act. Right. So this year we had an exercise with the participation of citizens, and we included the representation of the most common diseases which were being addressed. It was interesting to observe this because they understood that each group they saw each other's diseases, and this made them more empathetic to that. So if patients can take part in this process in a transparent way, this has to be done because this will make them become even better citizens. And if they can understand this, we can include the diseases little by little. The LJ program in Chile started with a design considering 56 diseases, and today we have up to 86 diseases. So people have to understand that incorporation of diseases to this list of the LJ program will happen gradually, and thus we can mitigate the problems that go along with that. Roberto mentioned that part of Antonio's questions was unanswered regarding the graph that Sebastian showed yesterday. They were saying that it would reach 90% of effectiveness in terms of coverage. This does happen, and it's explained by the first strategy used to prioritize the diseases. So how do you prioritize diseases with the highest burden? So we have to insert guarantees to cover a largest portion of the population. So in Chile, most people are covered. So those who need to be covered by certain disease are covered, because the main aspect considered in prioritization is the burden of specific diseases. A second point which I would like to mention, and modesty aside here, Andrea she designed the Ricardo Souza Act, and it's an act that's going to talk about more of the exception, and the LG program will talk more about the general public. So when it comes to the unit in the country, I think that we have to be covered. People have to be covered by public or private insurance, and this difference remains to this day. I will present two questions that were sent in writing to the panel. One is more related to health, and the other one is related to healthcare law and judicialization. I'm sorry that we don't have time to answer all of the questions, but those of you who have send your emails in the form. We're going to try to answer the questions and send them in writing to you by email. So make two general questions to the floor. First one is related to health care, and the second one is more related to judicialization. What are the challenges for the treatment of chronic renal patients? Renal patients, so that they have the right to dialysis and all other treatments. So what is that done in your countries? The second is more related to judicialization. The first question was made by Mr. Amaral from Votorantim, Minas Gerais. And the second question is by Mr. Firmo from the Justice Department of the State of Minas Gerais. The results of judicialization in your countries happen in which directions? Were they in favor of the plaintiffs, the patients, or against? So when you talk about judges' decisions, are they in general in favor of the plaintiffs or not? So what happens in your country? And the second part of the question is, with the same system prevents judges to oblige the state to offer everything at any price. Is that right? So that would be the question. And that would be the final question for this morning. About the legal decisions in Argentina, I would say that the courts are pretty much divided. It's a very polemical, controversial course. So there's a law that needs to incorporate a certain treatment, such as the treatment of infertility, incorporated into the public program. So, while this law was being discussed, we passed the law of equalitarian marriage. Now, infertility now is not only a physical problem of a woman or a man. It can be a problem of a same-sex couple, for instance. So, in the case of diseases, the courts have decided in very different ways. In some cases, they say that they even say how many treatment sessions the pregnant woman will receive. And then some other judges decide on a limit for 3 treatments for infertility. And so the decisions are pretty much different. Sometimes it's very costly to cover these procedures. So some judges will say that the patient will pay for part of it and the system will pay for other part of it. But in general, the judges are very friendly, plaintiff-friendly, so to speak. So, but there are some decisions that deny medical coverage. But for this to happen, you need to prove that there is no risk to the life of a patient. So, general, the risk to life is related. It's the first thing that they mention, the plaintiffs mention. Like, I'm Mr. John Doe, I'm in risk of dying or something, so that they can get treatments decided on. So we're trying to incorporate research in universities to determine pathologies and everything. It's difficult, but it's not something impossible. If you grant everything in favor of plaintiffs, you have a situation that can't be solved. Now, you have in Argentina, renal treatment is covered at an unlimited amount, so there's no difficulty. There's a waiting list, but the state covers every pathology related to the renal infirmities. So the public hospital is the one that regulates these waiting lists. Now, about the questions about the renal diseases, the question was related to the monetary cost. In Chile, the universal warranty that is oldest that we have is the one related to dialysis. For each dialysis equipment, the state transfers monthly payments to the companies providing this treatment. On the other hand, algae completely covers transplant expenses. The only constraint here as for a transplant is the number of donors, so there's no economic constraint there. If you've read the paper recently, you say that in the past 30 days, the most questionable treatment in Chile in the past 2 weeks is dialysis. And so what's happening in our country? There's a conflict of interests because the Chilean legislation did not provide for the installation of private dialysis centers, which today are the majority, but they are the same that prescribe dialysis in public hospitals. So the conflict of interests there affects the credibility of the medical profession. Personally, I can't believe a physician will prescribe dialysis that is not truly indicated. But the discourse that the press is given is that 50% of dialysis patients today don't need to be on dialysis. This is the message you get from the Chilean press today. So it's not a matter of resources. It's a matter of poor planning of how the resources need to be transferred to get the credibility of populations. So we have financed dialysis for years and years, and now we have this problem, and we have to address it as well. We also finance dialysis, and interpretations are complete, and hemofiltration in children is also financed. This is one of the diseases that has the largest coverages in Chile. So in Chile, judicialization when it comes to access to medication was not something that was alarming for the state. We have real facts so that we know which proportions need to be used in that matter. But yes, we have some decisions in favor and others against plaintiffs. I would say that decisions in favor of plaintiffs when they are arbitrary, this nature of being arbitrary will make judges force the state to pay for treatment that he had previously denied. And so the judges generally, they will decide against the public system in highly specialized prices when health plans try to have abusive increases in the price that they charge from patients, from those who are insured by them. Now, as for dialysis, because of the crisis, this has become a problem in the newspapers, in the press. The service providers have foreseen this situation, but the popular insurance couldn't keep up with the private one. So There is a public policy proposition for that. In the state, one of our largest states has a proposition. In that case, they would find federal resources, and for each dollar the state puts, they would put 5. They would match it to the tune of 5. So they would try to fight these diseases. Now, I'm not sure if all the cases are actually covered in that case. The other problem is that when the judges see what's happening in terms of judicialization, they allow the medication to reach the patient so that the problem is solved once and for all. So, and once they provide this medication to a patient, it's very hard to remove it, right? And this happened in lower courts and other cases that require intervention. So most courts are in favor of plaintiffs, of patients. Thank you very much. I'd like to make 2 important announcements. First, if you lost a golden earring, please come to the front desk with the police, and you can get it there. So we'll be back here at 2 o'clock sharp. As you've noticed, we don't have that much time. We have a lot of debate to make, so we'll be here at 2 o'clock sharp. And I hope to see you this afternoon and also tomorrow morning. Thank you very much.
Oi? É?
I can close The heart is a blow. Shoots up through the stony ground. There's no room, no space to rent in this town. You're out of luck, and the reason that you had to care, the traffic stuck, and you didn't move it anywhere. Before you found a friend to take you out of this place, someone you could lend a hand in return for grace. It's a beautiful day. Skies falls, you feel like a beautiful day. Don't let it get away. You're out on the road, but you got no destination. You're in the mud, in the maze of her imagination. Your love is down, even if that doesn't ring true. You've been a lover, and it's been all over you. It's a beautiful day. Don't let it get away. It's a beautiful day. Touch me, take me to another place. Teach me. I've known I'm not a hopeless case. See the world in green and blue. See China right in front of you. See the canyons broken by cloud. See the tuna fields clearing the sea out. See the bad oil fires at night. See the oil fields at first light, and see the bird with the lid in your mouth. After the flood, all the colors came out. It's a beautiful day. Don't let it get away. It's a beautiful day. Touch me, just make fun. And if you should, I only hear you. If I could stay, then the night will give you hell. Stay, then the day will keep its trust. Stay, Yes, I would. If I could, I would let it go. Surrender, dislocate. If I could through this life Did I disappoint you? Or leave a bad taste in your mouth? You act like you never had love, and you want me to go without. Well, it's too late tonight to drag the past out into the light. We're one, but we're not the same. We'll get carry each other, carry each other. Have you come here for forgiveness? Have you come to raise the dead? Have you come here to play Jesus to the lepers in your head? Did ask too much, more than a lot. You give me nothing now, it's all I got. We're one, but we're not the same. Will we hurt each other, then we'll do it again? You say, love is a temple, love a higher love. Love is a temple, love the higher love. You asked me to enter, but then you make me cry. And I can be holding on to what you got, when all you got is hurt. One love, one blood, one life. You got to do what you should. One life with each other, sisters, brothers. One life, but we're not the same. We get to carry each other, carry
many lost, but tell me who has won. That quenches love within our hearts. And mother, children, brothers, sisters turn apart. Someday, brother, someday. Someday, brother, someday. How long must we sing this song? How long, how long? 'Cause tonight blues, salvation in the blues. You never look like others, yeah. Yeah, yeah. Angel of Harlem. I have climbed high The heart is a bloom, shoots up through the stony ground. There's no room, no space to rent in this town. You're out of luck, and the reason that you had to care, the traffic's stuck, and you didn't move it anywhere before you found a friend to take you out of this place. Someone you could lend
tear 'cause I'm missing you. I'm still alright to smile. I think about you every day now. Was a time when I wasn't sure, but you set my mind at ease. There is no doubt you're in my heart now. Say, woman, take it slow. It will work itself out fine. All we need is just a little patience. Patience. Sit here on the stairs, 'cause I'd rather be alone. If I can't have you right now, I will wait, dear. Sometimes I get so tense, but I can't speed up the time. But you know, love, there's one more thing to consider. Say, woman, take it slow. It will work itself out fine. All we need is just a little patience. Say, sugar, make it slow, and we'll come together fine. All we need is just a little patience. Patience. Ooh, patience. Patience. I wonder how you're feeling. There's ringing in my ears, and no one to relate to except the sea. Who can I believe in? I'm kneeling on the floor. There has to be a force. Who do I fall? The stars are out and shining, but all I really wanna know, I want you. Show me the way every day. I want you. Show me the way. When I can see no reason, you're living on your nerves. When someone drops a cup and I submerge, I'm swimming in a circle. I feel I'm going down. There has to be a fool to play my part. Was someone thought of healing, but all I really wanna know, I want you. Show me the way every day. I want you. Show me the way every day. I want you. Day after day. Yeah. lasts forever, and we both know hearts can change. And it's hard to hold a candle in a cold November rain.
We've been through this such a long, long time, just trying to kill the pain. But lovers always come and lovers always go, and no one's really sure who's letting go today. Walking away, walking away. If we could take the time to lay it on the line, I could rest my head just knowing that you are mine. Oh mine, oh mine, mine, mine.
So if you want to love me, then darling, don't refrain. Or I'll just end up walking in the cold November rain.
Do you need some time on your own? Do you need some time all alone? Everybody needs some time on their own. Don't you know you need some time all alone?
I know it's hard to keep an open heart when even friends seem out to harm you. But if you could heal a broken heart, wouldn't time be out to charm you?
Do you need some time on your own? Do you need some time all alone? Everybody needs some time on their own. Don't you know you need some time all alone?
And when your fears subside and shadows still remain,
Been through this such a long, long time, just trying to kill the pain.
I know that you can love me when there's no one left to
But lovers
blame.
always come and lovers always go, and no one's really sure who's letting go today.
So never mind the darkness, you still can find a way.
Walking away, walking away, walking away, walking away.
'Cause nothing lasts forever, even cold November
If we could
rain.
take the time to lay it on the line, I could rest my head just knowing that you are mine.
Está desligado o microfone?
Good afternoon, everyone. I'd like to open this afternoon session of the meeting. The idea here is to continue the meeting for the International Meeting for the Right to Health, Universal Coverage, and Possible Comprehensiveness. We're going to have two panels this afternoon, one with members from Costa Rica, Uruguay, and Colombia, and the other panel we are going to have participants from Brazil. So we decided to do the first panel with the three foreign countries, and then we go and break for coffee. So I would like to invite Mr. Roman Navarro from Costa Rica. He's a legal advisor. He's a former consul for Costa Rica in Madrid, member of the Commission of Right to Health in the Attorneys College, and a lawyer in the Constitutional Chamber of the Supreme Court of Costa Rica. Mr. Rodolfo Pisa from Costa Rica. He is a lawyer, a former president executive president of the Costa Rican Department of Social Security and former deputy magistrate of the Supreme Court in his country. Mr. Santiago Pereira Campos from Uruguay. Dr. Santiago is a lawyer. He's a member of the Board of Justice of the American Studies Centers in the Ibero-American Institute of Procedural Law and the International Association of Procedural Law. He is also a professor of procedural law at the University of Montevideo. Mr. Arturo Echevarria from Uruguay. He's an economist, president and director of the National Health Board. He is a former general director in the Secretariat of the Ministry of Public Health in Uruguay. Also, I would like to invite to this table Ms. Mahi Bolivia from Colombia. She is a physician. It's a master in healthcare administration, manager of the Colombian Health Department, and a consultant with international entities. I also invite Mr. Nestor Correa, also from Colombia. He's a judge of the Supreme Council, is specialist in administrative law, and also specialized in public international law. Holds a master in public law with the University of Paris, and is also a professor at university. We clarified that after the lecture, each lectures in this panel, we are going to open the floor for question and answers in writing or orally. To organize this debate in a better way, participants can write their questions down in the form that's been handed out by the staff. If you wish to ask your question orally, please make a note in your form that you wish to do so. I'd like to make some clarification. The presentations of yesterday's panels and today's panels and tomorrow panels will be made into a book that's going to be electronically distributed in Portuguese, Spanish, and English to all of you. So the speakers will summarize the lectures that they are given here in this event, and we are going to publish this book. So we start the second panel, and with Mr. Roman Navarro. He will have 15 minutes for his lecture, his presentation, excuse me. Well, we're actually going to change the order of presentations here. We are going to have now Dr. Pisa, and he will have 15 minutes for his presentation. Well, thank you very much. First of all, thank you very much. Thank you, Renato, and to all of you, and also to my colleagues here in this panel. We're going to talk about the healthcare system in Costa Rica. Well, we have a universal healthcare system in terms of coverage and also social security. We have a special and unique story, just like any other country. And we would like to remind you that we have about $13 million of purchasing power per capita. Coverage, we have universal coverage and social security for the entire population. Today we have 94% of the population under the social security, and it's a national healthcare system linked to the social security in the country. About 9 to 10% of the Costa Rican population is of foreigners, so this leads to some problems in terms of coverage for this foreign population. We have a solidarity system. It's at least 10%. It's used by 12% of sanitary renderings in Social Security. 10% of people have received typical services. Because we have a solidarity system, 10% of the richer will have 10 to 4% more in health care than the poor, the more underprivileged population. They pretty much don't pay anything for it. It's a solidarity system, but we have a system that is called, it's related to the patient. So we have people who have access to this system. Since the judicialization of health, if you have a special access to the legal system, you also have a privileged access, which doesn't mean they are in a upper or lower social class. 10% of these people, that is, those who have a relative easy access to the healthcare support, we also include in these 10% prisoners. So the prison, those who are in prisons, they have legal representatives, they have attorneys, so it makes it easier for them to have access to the health system. So this system has there are two ways for us to enter this system. The health system is slightly fragmented. Over 95% of the beds in hospitals are working with cancer, labor, and heart disease. These services are rendered in public hospitals. And for medical appointments, we have about 80%. The majority of people tend to go to a private physician for their appointments. And then finally, we have the Social Security, which is 65% of the medications that are offered. As for the cost, Social Security spends about 40% of the money that is dedicated to medication in the country overall. About 40% of this is paid by the Social Security system, and then 60% is paid by the pharmacists themselves. We have health indicators, age expectancy of 80 years. Together with Chile, we have the highest ones in South America, together with Panama as well in Chile. The child mortality is quite low, also very similar to the one of Chile, but the system is an expensive one. At this point, between public and private sectors, we need to use between 10 and 12% of the GDP for health costs. So considering this 10.5% of the GDP, we have over 7% of public expenditure, including Social Security, and then 3.2% are spent in the private sector. Today, most of the expenditures of health most of the expenditure of the GDP in Latin America is spent with health. This is a map that shows that the countries that have a higher life expectancy and lower child mortality have systems that are different. So the Chilean system is different from the Cuban, which is different from Panama, and but all these four systems, they are different, but they are going towards the same indicators. There's a per capita income ratio related to life expectancy. This data is of 2005, and it shows that Costa Rica has high life expectancy, and it's actually higher than its relation with income per inhabitant. Here we have two phases of high growth for life expectancy in the 90s, in the early 80s, and then in the late 90s. And also in 2012, we had an important peak in terms of life expectancy as well. I was mentioning that this is an expensive system. We spend about $1,400 per capita yearly. So this is the largest percentage of GDP being spent in health in Latin America. And we even cost more than some European countries, very similar to what Germany and France spend. I'm talking about proportionally. Okay, so the public expenditure is dedicated to health, and there's a chunk of it which is dedicated to health. So 30% of this is spent on the private system. And then we have 70 to 80% of these 30 are going to the Social Security system. So in generally, we have 85, 86% of that. So Social Security spends over 6% of the GDP in pensions. So there is a high cost per appointment, in general $90. This is the average cost of a Social Security appointment in Costa Rica. So healthcare professionals represent an important chunk of the Social Security resources spent. So Costa Rican healthcare professionals are the best paid public employees. So a physician would make 10 to 15,000 a week, a month, and the nurses would make 5 to 7,000 monthly. So the expenditure with medication is about 90% of the overall cost, and it has increased over the past years. Judicialization causes a little impact to this point. It impacts 0.2% in appointments or 0.6% when it comes to surgery. So overall, it's less than 1%. Now, when we talk about medication, we say that we have about 90% of the expenditures there. And directly or indirectly, these expenditures derive from lawsuits. But the important thing is that the effects of judicialization represent less than 1% of the expenditures overall. Now, the expenditure has increased by 20% over the years, but the services haven't increased in that the same proportion. So people in general have been complaining about this. So we have benefits that haven't been translated or transferred to the population. This represents that the third level expenditure has reached 85%. Here we have expenditures with education and health. and health. This graph is saying that more spending doesn't mean that you have equality, that you have less poverty or anything. So our poverty levels haven't diminished at all. So the distribution of poverty has actually become worsened. And on the other side, the expenditures with education and social protection and health, we have increased expenditure there, but this hasn't been reflected in more health or more equity in our country. The same goes for education. The years that we have increased expenditures with education, the numbers really didn't represent that. So practically, we have a stabilized thing. We weren't able to translate more spending to better results. So here you have the public and private sectors. The public sector is funded by state payments and other entities as well. So when you universalize health in the social security system, you cover the more underprivileged population, and these people have more guarantee of health. Now, and this is not because they are all workers or dependents of workers. This happens because the state pays a basic insurance that is the same for everyone, including like 20 to 30% of the population. And we also have the biggest financer, which is the Costa Rican Social Security Fund, and we pay some services in the Ministry of Health with this fund, especially when it comes to nutrition, smoking, alcoholism. We also have private financiers. So health insurances have a private entity as an important player there that will deal with occupational risk. So this is how our system works a little bit. So from primary care to rehabilitation, levels 1 to 4 will be included in our coverage. So, of course, that this represents a very high cost, together with Uruguay and Argentina, which are the countries that have the biggest spending compared to their GDP in South America. The study is funded by contributions, mainly 7%. We have tax, and they are paid by the state, so that is 25% of the state is paid using these 7%. These are capital expenditures, and these contributions represent 55% of the private sector and 40% in the public sector. Here we have some phases of the Social Security. It was created in 1941, and the idea was to create insurance for workers and their families. And then the Constitution was established saying that everyone in the country should be included so as to reach the universalization of this healthcare. And this happens in the 90s. In the 90s, there was an economic crisis. I was part of the team that worked with this adjustment in the social security system there. And during that phase, one of the main objectives was to control the actions of the Ministry of Health and the actions that were done with the Social Security Fund. And this combination, so to do this work, we made a series of assumptions, right? So there's 1 in every 4 inhabitants. For 1 in every 4 inhabitants, we have a team that in primary care. So what are the threats of the system, the healthcare system in our country? So essentially, the economic and social system needs to support the healthcare system, even though the legislation might say otherwise.
There's also the topic of health judicialization, health ruled by court. It's related to social indicators. The demographic profile is also important. It's a system that has its weaknesses, and as a public system, it faces problems related to the elastic infinite demand and a limited inelastic delivery or supply of services. So the waiting list is based on a balance between demand and supply. There is also a growth of employees, unions, and also we have the population aging process. I'd like to highlight also that because of the growth of the adult population and the growth of the elderly, we see here how it is progressing from 13% of the population to reaching rapidly 17%. We must keep in mind that health expenditures with the elderly is above what is spent with the average of the population. It costs almost 18 times more than someone from 0 to 18 years of age, and 4.8 times more expensive than for someone younger than 64. So to meet the demands related to the demographic and epidemiological changes, we'll have to spend 2 to 3% more from the GDP to meet the demands of the healthcare system. I don't see when we are going to. I don't see in the future we spending 2 to 3% of the GDP. If we are able to contain the growth of the expenditures, and if we're able to keep the revenues at an adequate level, then things could be okay. But the most likely scenario is not that optimistic. But the national healthcare system is based on a very simple principle, and here quoting Lord Beveridge, the system cannot give it all to all, cannot give it all to some. It should give something to all. And we always will have limited services provided, however, good services. Thank you. Excellent presentation, very clarifying this presentation on the Costa Rica healthcare system. Now I'd like to invite Dr. Román Navarro, who will have 15 minutes to deliver his talk. Thank you. Good afternoon. I'd like to express my deep thanks to Antonio, Renato, Roberto, but also to each one of you who has welcomed me. You do beyond your duties, more than what you should. So thank you very much for your kind attention. Now, it's my task to talk to you from the legal perspective. And it's something that Rodolfo already mentioned. Well, the first thing that I must say is that it is impossible to talk about this topic from the legal perspective without understanding first that as of the first half of the 20th century, what we called neo-constitutionalism began, and rights, especially economic and social rights, and within this context will be more effective. They will have a legal value, a legal applicability, and all the legal and administrative system will make these rights feasible. And there are many basic principles, and they all have to do with international tools of human rights. And somehow there's a hierarchy, similar or higher than the Constitution, because in some situations they provide greater protection to human beings. Today in the Constitution there is some material content, and all the public branches, because we have a federative, either a federative system or a unitarian system, and we heard about both types of system, but whatever the system, no matter what the system is, it must be feasible. All the acts must comply with this context. The law should be based on rights and not the opposite way around. There are some important constitutional reforms. I must say that in Latin America, the movement in favor of health related to rights or just judicialization comes from a constitutional reform, and it depends on how these rights are taken care of. And there is always an experience of such nature. Of course, constitutionalism will lead us to wait. To waiting things when we are to make decisions, and no longer. And it leads us also to a protagonism played by judges. When we have constitutional jurisdictions that are concentrated and specialized, the role played by judges and their protagonism are greater than the lawmakers. So they are more protagonists in the system than lawmakers. And in Costa Rica, well, I have this slide here just to draw your attention upon the fact that it's not enough to talk about the principles that comprise the rights to health. Things are more complex than that. Our Constitution talks about the welfare of all the individuals in our country, and we also talk about a Christian principle of social justice. And in Article 177, we talk about universality and social insurance for the benefit of workers. Well, in order to achieve that, there's a number of principles that are needed. Universality, equality, equity, security. Well, I don't have time to explain each one of the principles. In terms of the organization, Rodolfo has already explained it, but I'd like to highlight something here. Somehow our system is based on a very old model related to social insurance. In Latin America, reforms were implemented to replace this model, but this model has advantages and disadvantages. Advantages, usually the services provided are uniform. There are no regional asymmetries in terms of the quality of service provided, but there are disadvantages because it's a public system. It's inefficient sometimes, and the waiting lists are caused by the fact that the system doesn't receive incentives enough to be more efficient. Reforms also have a virus in its DNA, and there's also the problem of judicialization, as many have mentioned before. In terms of private institutions, well, this happens because of access. They try to maximize its activity, creating barriers to some types of drugs, sometimes of procedures. So there are virtues and deficiencies, weaknesses. The reform improves some points and made others worse. Fundamental right to health, its configuration. It's a bit complicated, but rights have structure and content. I'm not going to get into the details. The only thing that is important to mention here is that there's a legal asset here, the assets that can be used in a positive and in a negative way. the key point here is to understand that this organization in terms of health services provision is not based on economic or social limiting factors. This is a key point. When a decision is made, the system has to establish some constraints, but the system cannot establish constraints related to social condition. Anyone must have access to services, healthcare services, to healthcare, and everything is based on a social warranty. We need to have the participation of the society as a whole. This is key to understand, because we're going to say here that the judicialization process doesn't consider this collective element. The right to health cannot mean medical care, cannot mean just healthcare system or be a synonym. But we always end up in the same thing. Rights to health being basically synonyms of healthcare systems. No. This reflects in 20% of the health of the population as determinants. There are other factors that are more important. Sometimes the life expectancy is changed because of a route that was created, drinking water, not because hospitals or clinics built, but sometimes simpler measures that do not belong truly to the healthcare system. So we have to change this perception and things. These are not synonyms. So the right is a social product managed by the government. And while considering our different countries, some name it right to health care, and others mention it as right to health protection. Some place emphasis in the protection mechanisms. Well, let's discuss the differences. Right to health, right to medical care. Well, medical care is a right that belongs to a certain gender. In terms of right to health, we have to consider health determinants. Everything has to do with health policies, but not only health policies from the Ministry of Health, but also everything that has to do with health is considered as a health determinant. Fundamental rights are interdependent and cannot be divided. The right to health leads to other rights, the exercise of liberty, and other rights that we call social rights or social economic rights, housing, water, etc. Things that I have already mentioned. Some people say, well, is it an economic social right or an individual right? Well, to me, it seems that this discussion doesn't matter. It's just like having a coin with both faces. There's an individual element. We strengthen the individual autonomy, which is an achievement of the rule of law, and is based on public norms and bans, etc. And there's also social norms related to health care provision. And other economic social rights are then included, and they were made possible because of the rule of law. And we have the topics of universality and comprehensiveness, and it all relates to scarcity. And the main discussion here is minimum health or minimum expenditure. Depending on the focus, the answer will change. The most appropriate one is what we see in the last line. To be feasible, it's unavoidable to have in a minimum health model to use some sort of minimum expenditure, otherwise it won't be feasible. And second, in order to provide satisfactory services, some sort of minimum health has to be accepted. And if the focus is on health and people's rights, most likely many diseases are not going to be listed. But because of social issues, these diseases must be listed, must be included. It's not, we shouldn't only think about in per capita expenditures. In Costa Rica, an epidemiologist talked about the pharmacological inequity, because very few people, less than 2%, have the highest or the greatest budget in terms of medication expenses. Well, of course, we're talking about oncological patients or rare diseases, and the one basis of justice is to give access to these services. Judicialization, well, in order to receive this name, it has to have some features. What are the features? The magnitude of the phenomenon. If we're talking about countries such as Argentina and Brazil, big countries, large populations, then we're talking about millions of people to be protected. If we talk about Costa Rica, 10% of the actions that are sent to Costa Rican courts are related to health protection issues or health access issues. And we have a political, financial, administrative impact. And this is seen in the public policies. Usually in these countries, the courts of justice are questioned or question the public policies. And what happens then? Important reforms are introduced. The perception of the phenomenon for the public administration is that judges are excessively protagonists. Judges believe that the system is not enough to have so many people entitled to them. And many benefits are not regulated by the system, and sometimes the structural sentences are issued by judges, sometimes in civil actions, or sometimes the type of sentences issued is not based on any jurisprudence. And of course, we have to have a social rule of law and the right to health care. And I'm here emphasizing something that Maris already mentioned in the previous presentation. The focus is on medical care. In most public systems, such as ours, the focus is on the hospital care. Hospital care is still, contributes little to the health of the population, 20% at the most. And hospital care contributes even less. Primary health care investments much more important in terms of the health of the population. But the judicialization process is very much focused on high-cost procedures and hospital-related costs. We have here justice system and the healthcare system, and those countries where access to court is easy or access to court is difficult. Look at what happens in countries where the healthcare system is privately regulated or a public system. Well, obviously, in countries, we can list Costa Rica and Brazil, in countries where the system is public and is regulated by the state. It has to do, and it has. The public healthcare system must be efficient to give timely responses to these claims. And most claims, most sentences favor the claimant. Of course, it is profitable for users to file lawsuits. Sophia mentioned Mexico and South Africa. I have studied the Mexican system, and they have a public system, but it's difficult to have access to health and the public health system. In Mexico, there are added costs to the judicialization process. And when there are these difficulties in the legal system, usually the lawsuits are funded by the industry or organizations. And the idea here is to have an impact, a structural impact in the system. In other situations, such as what happens in Brazil and Costa Rica, each case well, we have to solve case by case. Well, I'm going to conclude discussing how judges reason. Individuals make their own decisions based on their health status and what the physician says, the treatment suggested, and the budget available. That's how the decision is made. The health administration, conversely, when they perform this analysis, they consider the population as a whole, no longer one single individual. They consider the costs, the services package. I mean, they consider all that when they make their decision. Judges go back to the assessment of the individual, but the problem is that the judge deals with what we call financial irresponsibility, because he is not financially responsible for his decision. He doesn't consider the clinical considers the clinical variation, but he doesn't consider the financial impact and the impact of his decision in the society, or he doesn't consider a variable that we call collective element of the right to health. Someone asked me once, well, how can a judge consider the economic variable? And I always answer, well, based on the equity or equality principle. He could only make his decision if he could give the same sentence to all the individuals in the population. So to close, well, I believe that Chile, if I'm wrong, please correct me, my Chilean friends. From as far as I understood, well, in Spain, there's a constitutional warranty of health, but it can only be, well, the demands must be based on the law. In Latin America, a constitutional judge makes his decision based on the Constitution. But the difference is very strong here, because in the Spanish model reports to the law, and the judge is not a participant. It doesn't participate in defining the public policy. In Latin America, judges follow the Constitution, and especially in the concentrated models, because sometimes diffuse models that are ruled by law, but the concentrated models and the other speakers mentioned that, well, they make the decisions based on the progressiveness of the service provided, an extension of coverage, and in the rights to health. Thank you very much.
Román, muchas gracias, Rodolfo, muchas gracias, Costa Rica. Essa excelente exposição para nós compreendermos um pouquinho mais da saúde da Costa Rica. Dando continuidade e concedo.
I hand the floor over to the representative of Costa Rica, and he will have 15 minutes for his lecture. First of all, thank very much for the ALMG and Renato for having invited me to be here. I'm tempted to speak in a mix of Portuguese and Spanish, but I will speak Spanish. I'll stick to Spanish here. So, this is the presentation that, thank you. We are going to talk in this presentation, we are going to talk about the numbers and the aspects related to judicialization regarding healthcare in Uruguay. The first theme that we are going to be analyzing is what is the debate of regarding constitutional right to health in Portugal. So we acknowledge that this right exists, and the point of discussion is how broad is the reach of this right. And we have to ask ourselves if this is a subjective right or not. So we have to see if the non-priorities are included or covered. And we will also need to understand what is not included in the coverage. So do we only need a medical prescription for us to cover a certain treatment? We have to analyze the social impact and the economical impact, and how this also impacts this equality. So in Uruguay, we have a norm that generated the whole problem. So this norm was in the Constitution for many, many years. Try to read the last part here. The state will provide the means for prevention and assistance for those who are in need of sufficient resources, and this is going to be done for free. When we read that, we have the impression that the state is going to have to provide for even for those who have a reasonable income. If your income is $4,000 or $5,000 a month, you cannot pay for $2,000 treatment. So they will go and try to get this based on this text from the Constitution. So here we say that the state is responsible to care for the right for health, and what the state needs to do is to ensure that all these healthcare services are rendered. That's pretty much saying that you have to provide everything for everyone. And there's another restriction that says that we have to be careful to adopt solutions that disregard the social perspective and the impact that a decision can have in the principle of equality. And also, we need to ensure universal access and sustainability of the system. So the system in Uruguay has been built for over many years, and as of 2005, there was a new regulation that changed these two key aspects in Uruguay. So all inhabitants, all Uruguayans have access to the accounts of this system. So our integrated health system is financed through the tax paid by employees and employers. Our patients are insured by the system, and the service is provided by private or public service providers. And I think this is a very well-articulated system. We have public and private providers there in the system, and all the system does after the service is actually provided is to transfer the funds to whoever provided the system. We have a very broad list of treatments that are covered, but of course not all of them are covered. On the other side here, we have non-insured patients, but even though they may not be part of the public insurance, they are integrated in the whole network with lower resources, of course. So private insurance can be used by other parts of the population. So what happens in terms of prioritization? The process in Uruguay is quite technical. So we have the executive power prioritizing the treatments. And as we saw in the presentation yesterday, we have the prescription that is done by the physician to a patient, and then considering the list of priorities, we have the indication or the referral by the physician. And this might not be, this list is received without prejudice to the resources. So what happens to the non-priority treatments? This is the key to the judicialization. These services are subject to an outsourcing system. So if I want to receive a medication that it's not being used, I have alternatives to pay for it privately or via judicialization. So in judicialization in Uruguay today, we start from the point that we have a health system that increases coverage. And we also consider that the prioritization system doesn't cover everything for everyone. So we don't have one single, in Uruguay, we don't have one single lawsuit regarding services that were priorities and that had not been rendered. There's not one single lawsuit in there. So how can we make a complaint about these non-priority services? You have mechanisms, institutions that can be addressed, and we have the regional courts that can be accessed by the population. There are some initiatives in health and law areas in Uruguay, and as of 2015, the legal procedure is been defined by the executive power, and they established that if you are complaining to something that is a non-priority, you can make your claim in the administrative headquarters first, and will give a prompt response. We had two impacts related to that. The state acknowledged by norm that there could be procedures that were not included in the official list of procedures, and this acknowledgement is quite important when it comes to transparency of the system. Now, even though this might not be very fair, we still have to provide some other services. So, and this established that we can't establish a relation of casualty. And we had at that point, we had a high increase, and then ever since we started a drop. So what was happening is that somehow people wanted a response from the state. They were saying, oh, I don't get this from the state, but you have to tell me why I don't get that from state. So many of these claims didn't reach the courts. They stopped in this administrative board there, and the result of this is that this inefficiency wasn't transferred to the judiciary. So in Uruguay, if you can't pay for a lawyer, you are going to have legal aid from students in law school, for instance. So what we notice is that judicialization is a recent phenomenon that started in the year 2000. It has a moderate impact, and the evolution is quite gradual throughout these years. So here we have some key questions. We want to know, how does litigation work in healthcare? The first question is, who is the litigator in different countries? Is it the lowest income population? Is it the medium income population? So who is bringing these suits to court? The next question is, why are these suits being brought to court? And here, lawyers say that the big pharma industry and lawyers are the biggest motivators of the process. there's a train of thought in Uruguay that says that the press is the biggest motivator. So if someone claims for medication and the press says and circulates that that such medication was granted by a judge, this circulation of information will motivate others to do so as well. So what we can see here is that the legal system shows which level we have here. Here we have which kind of dialogue or which kind of tools judges use to establish a dialogue with society. So what do they consider in that judgment? Is it life? Is it healthcare? Is it equality? Is it economic factors? So it's essential to have a prioritization here, and the role of it is very important. So people want to know who is establishing these priorities, how they are established, and if there is any participation of the public in that process. Of course, we have other essential questions as well. What happens to judicialization and the sustainability of this system? To which extent can the system bear the burden of providing treatment to everyone? And I have a small confession to make here. When it started here, the discussion of judicialization, for example, was something absurd. It was a bad word. We were seen as judges that wanted to break the rules in the system. And this dialogue, both on a national and regional level, showed us that judicialization is sometimes the tool that the common citizen has to enter the system, to access the system. And the biggest problem there is how to make this kind of justice dialogue with the common citizens. Now, another aspect that must be seen is equity. So, another question is who can bring suits against who can bring suits related to the healthcare system in Uruguay? My answer is that pretty much these suits are being brought against the government. In Uruguay, a patient taking the same medication with the same pathology can go to different judges, and one will grant it and the other won't. So this kind of situation can reach a court of appeals, and people don't understand how two identical situations, two patients with the same pathology, with the same medication, have different decisions being made, one in favor and the other one against the other patient. So here we have, in Uruguay, we have judicialization system in the healthcare system that tries to prioritize the general interest. We have to try to ensure equality in the whole system. And we need public policies that need to be defined by the legislators and by authorities as well. And we have to be careful to maintain the principle of a separation between the powers as well. A short time ago, we talked about the inconstitutionality of a norm, saying that for high-cost medications, patients could only receive those who were priorities. Now, this has led to a lot of debate, and the impact of this dilemma is something that we can't assess at this point. So we have unlimited demands, but we do have limited resources. So the judicialization process needs to be seen as a dialogue, not as a face-off or anything like that between patients and justice. Now, some conclusions here is that the means of communication generate a very complex situation. Here we have a country with diverse interests, such as Brazil as well. In Brazil, in Uruguay, we don't have the right models yet. And the question I ask myself is, what's the definite difference that happens here with other rights, the right to education, the right to housing and everything? And another question is, what will happen if these rights that are being ensured in healthcare are transferred to other rights as well, such as education and housing? So to conclude, I would like to mention what Renato said. I know physicians don't like it very much. But if the process starts when the physician prescribe the treatment or the medication that is non-priority to the patient, they have to indicate why they're doing so. So physicians have to explain why it makes sense to prescribe such medication or treatment to a given patient. So this is the process we have to inform so that we can provide technical information based on evidence, and this will allow them to come to the right decisions. I'm a pessimistic in that regard. I believe that if we don't have an open debate and if we are unable to make society understand this, and understand that we can't give all to everyone, the system is going to collapse. And the impact, the question I ask myself is if the impact of this right is utopic or not. Thank you very much.
Academic wealth. It was great to hear about compared law. Now I'd like to invite Dr. Arturo Echevarria, who will have also 20 minutes for his talk. Good afternoon to all of you. I'd like to thank the World Bank and the State Legislature for this invitation. It's a great pleasure to be here today. And more than sharing our experience, we are learning about the different systems. And we see that we're not alone. We are facing common problems. There are many commonalities among our countries. And we have to advance collectively, just like it's been done in some areas, such as purchase of medication. Well, the Uruguayan integrated healthcare system is
Es un sistema nuevo, es un sistema que tiene unos pocos años, entonces nosotros...
Our system is a new system. We talked about a new reform, and many of the previous systems were very heterogeneous, and the public system provided services, health services to almost half of the population, and it would spend 1/3 of what the private sector spent. A lot of imbalance. The coverage was only for workers and retired people. So in Uruguay, the benefits would be interrupted after the worker retired, and In some cases, the coverage, which was extended to sons and daughters, would be interrupted also. And there were many deficits, and one of the roles of the system was to provide health care to the poorest population. This healthcare model was medical-centric, hospital-centric, was fragmented. We didn't have healthcare teams, and we had and still have a duplication of human resources and a need of resources, and this happens throughout the country and also in the area surrounding Montevideo. We have most of the resources in this area. We also have very serious problems in terms of human resources. Human resources training is centered at the university, of course, but there are many restrictions when we think about some specialties. The reform and the proposals for change. Many stakeholders involved in this healthcare system reform, and the reform it was not created with the idea of deleting everything that existed. We thought about specific points of change, a slow, gradual change. We tend to say that Uruguay is a country that doesn't implement radical changes, just gradual changes. Here we see the timeline from this moment until 2016, and we see that different changes were gradually implemented in the system, integration of different players, different users, and now on July 1st of 2016, we had the last collective group of retired people joining the system and having access to the healthcare services. Health is a human right from the individual standpoint. Each citizen is entitled to health care, to have a good quality of health. We also have the collective perspective, the health care provided to all inhabitants. But here we have to think about the main goals of the reform: universalization of the health care system in terms of homogeneous access and equity, and with justice, a fair system in terms of per capita expenditure. So here we have more than universalization. The access to health care is a very important topic. We have social determinants in Uruguay, just like in other countries, that interfere with how fast people have access to health. Geographic factors, social, cultural, economic factors. I mean, Uruguay is not a big country. From one extreme to the other, we have only 600 kilometers, and transportation is easy. But these problems also exist. We have three main axes: changes in the healthcare model, emphasis in the primary health care, changes in the model including participation of workers and users in the way the system is managed, and changes in the funding model. This is where we have been advancing the most, and is the system that was more quickly implemented. The integrated healthcare system, the Ministry of Health became the main health authority, and we have the administration of the national health insurance, of the health insurance system, and provincial health accounts were created, and we had broader representation of the stakeholders engaged. So all these changes. So what about the service providers? The service providers already existed before the reform. The state and medical institutions, other healthcare providers are pre-existent. The main players are hired, the main service providers are hired based on a program that is signed by the National Health Board with each one of the providers. The system has other providers, the clinics, hospital, the military, police, health system, and other systems that you see listed in this slide are also part of the system. Users, there are 3 types of users in Uruguay. Individual users, they have to pay a quota, just a few hundreds of people do that. Those who have free health care, those who have, the people with low income are entitled to health care services for free, and they have full access to healthcare services. And we also have individual private users who pay a quota or have a private health insurance, the HMOs. Also, we have the army hospitals, employees from the Ministry of Defense, and we also have public and private workers. We have spouses and dependents. And the sons and daughters of the workers and the spouses of workers, they all are entitled to healthcare services through the FONASA. So they may access either the private or the public service. So people can buy private health insurance just paying a complementary quota. But this is going to change in 2015 because, like I mentioned, in June of this year, a group of retired people joined the system, and 70% of the population was covered by the FONASA. We have a system that allows us to regulate the mobility that we have among the different institutions that are part of the FONASA system. And besides that, there is the possibility of changing the type of health care system, changing from one to the other. Here we see the user-provider ratio, and the last figure here says 2%. And here we talk about people that could not be covered. Imagine someone that's not the son or daughter of a worker or a spouse, or if he or she is older than 18 in the case of sons, but this person has no income. So imagine his or her situation. And this person has not enrolled in the system. People who still need something to get done to really exercise the right to health. Here we see that 30% of the population is covered by, 57% of the population is covered by collective health services. Here we see the strategy that I mentioned that we had before the health reform. We changed the funding and the management model based on the goals of universality and sustainability. We created the National Health Insurance, and this is what compounds the system. We also had changes in the management model. An important change took place in the organization of health. We have an institution that is now part of the ministry. We have 4 people represented we have 4 people representing workers and users in the executive branch, and also representing the healthcare providers. Among FONASA competences, we have the ability or capacity of disposing of the payments received to safeguard the guidelines and to provide to users healthcare coverage based on signing contracts or agreements with each one of the providers. These contracts are signed and monitored by the public government and by FONASA. There are some details here related to changes in the management model that I'm not going to get into. We have some other players that are part of the boards and other institutions such as bioethics, patient security institution, etc. So this came along with the reform. Changes in the healthcare model. This is the second main axis of the reform. One important aspect of the system is that it generated a comprehensive plan of health care, which describes all services to be provided, medical specialties for diagnostic procedures and diagnosis, vaccines, sanitation, etc. So we see here that all the rights are explicit. So comprehensive health care providers must comply with this comprehensive health plan. Also, the complementation of services is part of our model of healthcare. It's not ruled by law like in other countries, but the Ministry of Health and the different boards are putting forth the best efforts to have it playing this role, the complementation of service, to have it implemented. The complementation may range from purchasing some services, for instance, X-rays from one institution, purchasing them from the other, or sharing emergency rooms, common physicians working in the same place to prevent from having a duplication of services in small locations. This, of course, goes against the market interests and logics. They are trying to fight against this complementation of services. Of course, we are trying to give the best use to limited resources that we have, preventing duplications and achieving economies of scale. There are changes in the healthcare model. We have now, physicians, I think it's a common feature. They work in multiple institutions. So now in Uruguay, we are trying to have physicians performing full-time jobs, 40 to 48 hours per week at the same institution. A physician may play different roles or perform different services in the same institution, and the result, but full-time and at the same institution. We are getting excellent results in terms of patients, hospitalized patients in the ICU, because the same physician sees the same patient, and we don't have physicians on duty for, just once a week, seeing patients once a week and seeing the patients again only in the following week. So I have 1 minute left only. Well, so changes in the funding model. Users contribute according to their income to FONASA. This contribution is 3% for low-income individuals, 4.5% for those without spouses or sons and daughters, 6% for those with sons and daughters, and 2% extra for those with sons and daughters and spouses, and 5% as the complementation given by the state. So this is the way they contribute to the fund. The fund is paid by service providers according to a budget cap that is not the same for each individual. It considers the age and the gender of the users to see how much they will pay per capita. And providers are those who provide comprehensive care through the PS system to the users. So here we see the graphs of men and women in blue, men, and red, women, as a function of age and gender. And we see the relationship between between age and gender here in terms of per capita expenditures. Another important change in the funding model is the incorporation of healthcare targets or goals. We propose targets to healthcare providers. As they reach the targets, they are able to, they are paid more. They receive a premium for these services. And it's important to have this incorporated by different institutions. Some of them are also including their own targets. And we have now national health targets. So this target tool is a very important tool to make sure that besides complying with the peers, the health providers will contribute to advances in this field of healthcare. In terms of moderating taxes, we are trying to reduce them. Public expenditures have increased a lot in this period. The National Fund, the National Resources Fund is a fund used for high-cost treatments. Well, it started with that, but now it pays for more than only high-cost procedures and rare diseases, and we have highly specialized medical institutes. Well, the economic features not included here are related to judicialization, because this is not part of the budget. It's not included. Judicialization is not included in the budget. When the Ministry of Health, because of a lawsuit, has to pay something, it's not included in the budget. And the figures are very important because these payments have been growing, almost a tenfold growth from 2005 to 2015 in 10 years. So here we see the increasing cost because of the judicialization. Another important feature to highlight here is that usually we have two causes for lawsuits: oncological drugs or endoprosthesis, stents, aortic stents, for instance. And oncological drugs are the ones that are not listed in the PS. We do have several oncology drugs that are listed in the PS, but those who are not listed are not there because the Ministry of Health doesn't consider them as being effective enough to be listed. Here are some figures related to funding sources and funding agents, but I've overshot my time, so I will close now. Thank you very much.
Obrigado pela exposição.
Thank you very much for your presentation. We need to understand management in addition to understanding legal aspects as well. The presentations that are being shown to you will be made available on Monday on our website, on the ALMG website. So continuing the presentations now, we are going to have Dr. Bolivar from Colombia. She will have 15 minutes for her presentation.
Buenas tardes.
Good afternoon, everyone. Thank you very much for the ALMG and the World Bank for having invited me here, and thank you all for your hospitality. Now, we are going to present the health care system in Colombia, a 20-year reform. I will use the information from other presentations from my colleagues that presented before me, so I won't delve into many of these data. I will present the data of Colombia, and I will go into details and other things. So this is what the organizing committee of this event has asked me to do. So we are going to see a general context of the country. We have 47 million people in Colombia. It's about 76% of the population lives in urban areas, and we are median income country according to the World Bank classification. Just like other countries presented here, we have an index that concentrates income that shows that we have quite big inequality in our country. Here I will show some slides that compare us with other countries so that we can see where we stand. The per capita GDP in Colombia is between $10,000, and we have something that is lower than Mexico and Chile, who are also here. Inequality is also constant here, and we can draw a relation between the people that represent 10% and of the income. So we are among the most unequal countries, and this is a very important variable for us. In the 90s, as for the right to health care, we had a new constitution in 1993, which addressed the right to health care as a health of all citizens. So this should be under the state. At that point, we had 23% of our population covered, and it was a fragmented coverage, just like the other speakers from other countries mentioned as well. We had health care plans only for affiliated people, and expenditure was to the tune of 47%. So the reform said that our aim was to have a universal coverage and to respond to people's needs through a comprehensive health care plan in the country. This is a solidarity system, and it should provide for healthcare protection to the entire population. And this is how the 20-year-old program has been developed, has unfolded. So we transformed this social rights to fundamental rights. So fundamental rights in our country are subject to legal protection and support. So before this reform, we had a protection for health care, but also for other aspects as the right to life and other ones. As of 1993, we were able to provide protection against problems with the healthcare system instead. Today we have about 95% here. In the vertical, we have a financial protection installed here, and this is the best financial protection in Latin America. It's to the tune of 14% of expenditures, and we have unified coverage. So there's a limit for those who can pay, and there are subsidies for those who cannot pay, in which case the government will finance their expenditures. Now, all the topics related to activities and procedures that are not proven to have a clinical efficacy and security, and other services that are rendered outside the country as well. This will include all that, as well as trial studies and everything. So we cover since a simple doctor's appointment to high-cost treatment for renal diseases, for cancer and all. So all pathologies are covered. Our limits are in the procedures, not in the pathologies themselves. So anyone who has any kind of disease can access the system. The restrictions regard the procedures themselves, not the pathologies. So this is what we have today. We are quite interested in geographic variations when it comes to healthcare, because when you look, we observe here we have a coverage of up to 96%, but if we break this down into regions, we see that the inequality is very big. So in the country, we have some regions that are poorer and that they need more subsidies, and richer regions will need less subsidies. I would also like to comment that in addition to the mandatory healthcare plan, we also have other insurances that cover occupational incidents, for instance, traffic accidents and others, and they complement one another. We are going to see the healthcare system now. All of our health indicators have improved, such as life expectancy and everything. Our health, our resources destined to health have also improved. Our GDP is, we are spending over 88% of the GDP with healthcare. So we have 3.7 per inhabitant, together with Mexico and Chile. And when we talk about our GDP, we see that we are spending 6.8%. This is an important advance for us. We have these resources being targeted in healthcare. Now, when you observe expenditure per person, you see that this is a low expenditure, and this will lead to efficiency in the system. Of course, it's not 100% efficient, but it is efficient indeed. So this is under the Ministry of Health and other monitoring entities. We have something similar to the FDA in our country as well. And our system is not a centralized one. The municipalities also play their own roles. We have a fund that will transfer the funds to the providers, and we also have a very safe healthcare system. This is the map. The state is in the middle because it regulates all the players and the payment to all the providers, considering a standard of quality and ensuring that the guarantees are given. Now, here is the resources from payment of taxes by society. They can be municipal, regional, or national. They will go to a fund, and the fund will pay even all the insurance companies a per capita value per inhabitant, and this way health services can be insured to the population. Here's the entire system and all the resources that are used in this system. Now, when you represent this expense, we have 72% as an expenditure on the government, on the part of the government. This is one of the highest in Latin America, even higher than some developed countries. As for judicialization, this is an important phenomenon for us. The blue line talks about general numbers, and the red line is numbers for Colombia. This behavior was quite important. regarding the year that I mentioned to the right of the right for health, 42% of the lawsuits brought were about the right for health. So what happens to this? Over time, these values that would be about 500 people, what happens today is that we have doubled this number of people. And when you have reimbursement of insurance, this happens through price regulation, which I'm going to mention further on. So the per capita reimbursement is smaller now, and more people want to maintain their healthcare services. So judicialization represents 10% of the overall expenditures that we have on the subsidized regime. So here we see how these lawsuits are being brought in the subsidized system and not. We have some food, some even diapers being subsidized here, and many aspects are much more related to being able to have a dignified life than to anything else. So what was the impact that this caused us? We have an organized plan there, and this led to prices that were not regulated, and there was a rush competition between the big pharma companies and the insurance companies and everything, and all this was against the state. So what are the technical limitations that we have? This is a list that we share with other countries, and that show the aspects that hinder the system. The aging of the population is one of them. Epidemic diseases, chronic diseases in the 90s, and in 2013 we had a big increase of chronic diseases and a reduction of transmissible diseases of external agents. We still have high mortality. We have a chronic renal insufficiency or disability. We have 85% of the patients that have other pathologies. The other ones would be only 15% of these more serious diseases. Another interesting aspect is that when you look at Colombia by region, we see improvements, but there's still a long way to go. In the year 2000, we see that our mortality rates for children has reduced, but we still have to deal with some structural problems that are very important, as I mentioned before. So here we have some problems related to self-medication. Also, smoking is a problem. The expectations on the part of the population is also very important, where people have are satisfied. Our expenditure has reduced slightly, and the control of epidemics have been an important factor as well. So the use of new technologies has provided more expenditures, but not necessarily been translated into improvement for the population. So what are the policies that were implemented in the country? So universalization, so we have unified all the plans, we have expanded the plans, and currently we have development of a statutory law for healthcare, and the cautious use of resources by law. I will not really give a lot of details about this, but it's just important to mention. So what are the lessons that we learned in Colombia? We understand that we need to have a social pact, a social agreement. So we need to see what are the needs assessed by the experts. So what are the expectations of people? What resources are available? And an awareness of the double responsibility for the individuals and for the population as a whole as well. So objectives have to be aligned with expectations, and resources have to be translated into public policies that materialize the right progressively in an increasing way. So we have to reduce risks as well. And finally, we have to prioritize treatments as a strategy to use resources better. So we have to create value. Sometimes there's an area that you have more expenses, but they're not effective areas. So finally, we need to have a transparent decision-making process with the participation of the population. We often consider that the plans are well made because they're good technically, but they don't address the needs of the population necessarily. So we need to be aware of technological advances. It's hard to come to clear rules for that, and we also have to find rules to use the resources the best way possible. Thank you very much.
Thank you, Mary Bolivar. I see that Brazil shares some commonalities with the Colombian system. Since 2014, when we were there, I had this feeling. Now, to close this second panel, I'd like to give the floor to Dr. Nestor Correa, who will have 15 minutes for his talk. Good afternoon. To me, it's a great honor to be here in this beautiful city. I'd like to thank the state legislature, the Court of Appeals, and the State Attorney's Office of Minas Gerais, as well as the World Bank, for giving me this honor to be here. I'll try to be brief, trying to be more analytical than descriptive. The outline of my presentation is based on 3 parts. The first, the reach of health digitalization. The second part, the solutions, and the solutions which are not implemented. And the third part, the solutions that could be implemented. In the first part, the reach of health digitalization. Well, in Colombia, the efforts are people are devoting 1/3 of their time and resources to judge lawsuits, and out of them, 30% are related to the healthcare system. In the first quarter of this year, we had filed 625 lawsuits, 68 per hour. So this judicialization of the sector leads to many problems. I will mention 6 problems. 1, the judge replaces the Congress when in the allocation of resources and expenditures. They don't know the system of separation of branches. Judges were not elected by the population. Well, second, the sentences have a financial cost that interferes with the budget planning that has been, the budget is planned by technicians with a lot of time, and the sentences interfere with that. Third, they don't consider the prioritization of expenditures. There are winners and losers. Sometimes it's not based on scientific evidence, and lawsuits sometimes are backed up by the pharmaceutical industry or lawyers. Fourth, sometimes the protection has a regressive effect because not necessarily the poor are benefited. For instance, we have poor provinces where there are not, but there we don't have as many lawsuits as in the large cities. And lastly, the large amount of lawsuits that have to be judged more than penal, labor-related, and other and civil suits make the system, the legal system, slow. That leads to problems. And secondly, the judicialization has been leading to some redistributive and democratic effects because neither the market nor governmental authorities have really been responding to this demand. And if not for these lawsuits, the vulnerable groups of the population, indigenous groups, women, the poor population, excluded groups wouldn't really have effective rights to comprehensive health. Well, summarizing this first part, health judicialization has had mixed effects. On one hand, we cannot state that we have a better cost effectiveness of law, but we may state that we have that we see that people are what can we do with that? Now we'll move to the second part of my talk, the solutions that are not to be. Obviously, there are no 100% solutions. Well, poverty is inherent to people, to countries, and by itself, it is a chronic and lethal disease. And the possible comprehensiveness, right to health, these things don't exist. We have to reconstruct this concept. I will mention that in my conclusion, but I'll say it here, we have to assemble this model with the participation of all, just like we're doing here, participation of different authorities, but it's a slow process that is accomplished gradually, little by little, just like an ongoing, constant social pact. On the other hand, it's important to allocate a certain percentage of the public budget as the minimum amount, but to say that it's going to be 1/12 of the budget, well, that doesn't make sense. The budget, just like, the same applies to education, and to different members of the families or disabled people, and if that's the way we establish how much what percentage of the budget is going to be spent, well, we're going to get nowhere. Also, we shouldn't do what shouldn't be done in Brazil to have an ideology here in this debate. It's not a right claimed by the left wing. No, it's a right of all, and we shouldn't have we shouldn't count on an aristocratic, elite-based system to solve problems. The system, we had chances to organize successful healthcare systems, but so far it has failed. And that leads us to the third part, the solutions that could be. To include in our, we must introduce in our budget planning questions related to rational and positive judicialization of the right to health. First of all, in Colombia, the judicial structural approach by the Constitutional Court has been a positive, equalitarian approach, and the effects are being democratized. In effect, we had a sentence issued 740 in 2008 that made concrete some rights that existed only in theory. In Colombia, just like our neighbors mentioned, we are lawyers and physicians suffer from normative schizophrenia because the text says one thing, but we do the other. And sometimes, despite of what texts say, the reality is cruel, and we suffer from this reality. And the the Constitutional Court really made it possible to implement what is written in our texts. So we must really have strong laws related to right to health. We need laws that are flexible, to respecting the separation of the executive and legislative and judicial branches. And third, we must have effective rights to health. Secondly, we must limit the judicial intervention, individual lawsuits to extreme cases. For instance, situations in which the right to health is extremely threatened, or in cases of lethal diseases. Well, in these cases, judges should require stronger arguments. Now, except from exceptional cases, in an ideal world, judges should be limited to official health care plans and systems. Third, we must strengthen alternative mechanisms of conflict solution, mediation, conciliation, and we have some experience with that, and with the guidance of the World Bank. Very interesting experience. Also, we must provide better training to judges in terms of the reach of rights to health. We could make a better use of the information technologies to offer, to provide online courses on drugs available, different types of treatment, etc. Fifth, we should strengthen or improve a permanent diagnostic process of disputes involving the vulnerable population. We have to measure, monitor, follow up it. Sixth, we must have a better economic capacity. And we must consider the economic capacity. Some people can't afford the treatment or the drug prescribed, but the income of those who filed the lawsuits is not taken into account by judges. And lastly, just like our Uruguayan friend mentioned, we must strengthen the institutionality and the information of the dissemination of information. And this is not that it's bad, but we have to strengthen it. Well, in conclusion, well, I think he's about to interrupt me, to throw me a shoe, because my 15 minutes are over. Anyways, virtue is in the middle, an intelligent balance. In the past 15 years in Colombia, the healthcare system has been constantly including. When our population was only 20 million inhabitants, just like the population of this state of Minas Gerais, only 23% had access to health. Today, our population comprises 46 million inhabitants, and 60% have access to health, despite of all. What do I mean with this, despite of all? Well, Colombia has been in war for the past years. We have 8 million victims, 200,000 deaths. We have an armed conflict with the FARC, then narco traffic, and we have earthquakes, volcanoes. Well, our history in the past 50 years has been terrible, and even considering this terrible history, we are constantly improving in the health sector. We have to give it time. Let's wait for some time to go by. Our population is very young, so let's give it some time. But let's be more efficient so that time goes by faster and things happen faster. Health funding, health comprehensiveness are a toolkit, a model to be assembled, including ethics and life. So our fate is to put together this model, to assemble this model. Thank you very much.
Obrigado, Dr. Raul.
Thank you, Dr. Raul Correa. It's great to learn a bit more about the healthcare system in Colombia. We have many similarities if we compare the Brazilian and the Colombian system. Questions directed or addressed to the panelists are going to be answered along with the questions addressed to the panelists of the next panel. We're going to have a Q&A session or a debate at the end of this afternoon. Those of you who have not enrolled yet, please go to the registration desk. I'd like to highlight the importance of having all of you present here in the presentation that we're going to have after the coffee break. The certificates are going to be made available to participants enrolled tomorrow morning. You can get your certificate at the registration desk. Right now, we're going to have a 15-minute coffee break. Right after the coffee break, we're going to begin our third panel on the Brazilian healthcare system. After the Brazilian panel, we're going to invite panelists from panels 2 and 3 to answer questions. So thank you very much.
I sit and watch the children play. Smiling faces I can see, but not so strong that I can't disguise all night. Spend the night together, but I just can't apologize. Spend the night together. Don't hang me up and don't let me down. Don't let me down. We could have fun just moving around and around. Giving up your social world, you can't come back and be the first in line. You're absolute, my baby, my poor old-fashioned baby. I said, baby, 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 you're out of time. Well, baby, 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 you're out of time. I said, baby, 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 you're out of time. Yes, you are left out. Out of there with out of
don't need no juice in my crown. 'Cause all you women is slow down gamblers, cheating like I don't know how. But baby, there's fever in the funk house now. This slow down reaching got my poor feet itching. Don't you know the deuce is still wild. Baby, can't stay. You got to roll me and call me the tumbling die. Always in a hurry, I never stop to worry. Don't you see the time flashing by? Honey, got no money. I'm in sixes and sevens and nines. Say now, baby, I'm the rank outsider. You can be my partner in crime. Baby, I can't stay. You got to roll me and call me the tumbling. Roll me and call me the tumbling dice. Oh my, I'm the lone crap shooter, playing the field every night. Baby, I can't stay. You got to roll me and call me the tumbling. Yeah. Got to roll me. 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 Got to roll me.
Boa tarde a todos.
Good afternoon, everyone. We are going to continue with our panel now in this international meeting. Now we are going to have a panel with the Brazilian members, the Brazilian delegation, and we are honored to invite Mrs. Mariana Figueiredo. She is an attorney with the federal government. She's a master's in law and a postdoctorate with the Max Planck Institute in Germany. We're also happy to invite our colleague, Mr. Osvaldo Silva. She's a deputy prosecutor with the state government, and he's also a collaborator with the technical chamber in prices in healthcare. Now, without much further ado, we're going to go back to our agenda. We would like to hand the floor over to Dr. Mariana Figueiredo. and she will have up to 15 minutes for her presentation. Good afternoon, everyone. First of all, I'd like to talk about my joy to be here in the state of Minas Gerais. Your hospitality is so genuine. I'm always very happy to be here, very happy to be in this panel with these two colleagues here, Zumar and Osvaldo. Our idea here is to talk about the Brazilian Unified Healthcare System, the SUS. So we know the SUS well, and so that's why I'm going to briefly go through the characteristics of the system, and that we would like to try to understand why is this system is the way it is, and the challenges that the Brazilian SUS system faces. So a little bit of the history is the following. Before 1989, we had a different reality. I think we couldn't technically talk about a healthcare system before that date here in Brazil. Some other people have mentioned that already. We had a lot of problems in terms of fragmentation. So the first fragmentation that we have was institutional. That is, the idea of protection and assurance of health was distributed under the competences of different ministries. So the health ministry had some competence, and the social security ministry had other attributions. The Ministry of Education had other attributions. So we had lots of entities in the federal government that were dealing a little bit with the pieces and bits of health. And so together with this, the Brazilian system evolves from the system that is called a Bismarckian system. So it's an insurance system, and we evolve into a universal system. So why did this migration happen? The idea was to overcome some problems related to fragmentation, especially when it comes to coverage. And when I say coverage, what do I really mean? So the system that we had before 1989, I'm not sure if I can call it a system, but the health plans that we had before that date, they were connected to the social security funds, pension funds, and which in the future became the National Social Security Institute. So during that time, we had assurance of health to those who had a legal formal employment, and also this was related to some specific professional categories. So the healthcare guarantees, they were similar, but they were not equal, because each pension institute and retirement institute had a given configuration in the healthcare area. And by doing so, we have a lack of uniformity in coverage, because depending on which profession you had different coverage. And we also had very important problems in terms of the restriction to access. So access was available for employees in the formal market and their families and wives and husbands. But this would leave us out rural workers and informal workers, unemployed people and everything. So the idea of the SUS was to be a public policy. So this back in 1988, there was a time in which Brazil was leaving 25 years of dictatorship. So we were talking about the healthcare reformation in Brazil, and this movement gathered the community. There's a lot of social participation on the part of citizens. And what they were fighting for back then was to create the concept of health as a fundamental right. So in this healthcare movement, climaxed in the 8th Healthcare Conference in Brasilia in 1986, the conclusions of this conference were taken to the Congress as a framework of how healthcare should be organized in the country. So this is the historical aspects, and it's important to understand that so that we can understand how the SUS is organized today. So why is it egalitarian? It's equalitarian because we wanted to include those who once were not included before 1998. So the idea of the SUS was to include all citizens in the system. And also the idea of equality is that everyone should have access regardless of having a formal employment or not. This is a very strong idea, and it's a very dear idea for anyone who fights for healthcare rights in Brazil. In addition to that, you have the principle of comprehensiveness, that is, all the difference of coverage in the different professional areas. So that is, there was an attempt to equalize that so that people could be insured to have the same coverage. And then after that, we create the idea of the right for health care. It's important to mention that because this distinguishes the Brazilian system in comparison with the other countries that are present here. Here in Brazil, healthcare is a fundamental right. It's a social right under the 6th paragraph of the Federal Constitution, but it is a fundamental right. It has the same prerogatives and regime of any other fundamental rights in the country, including individual and political rights. So there is a difference in concept here in Brazil. Someone mentioned the Spanish Constitution. So the right for health is one of the drivers for economic order. It's different in Brazil. We have a difference between the rights, the liberties, and the guarantees. In Brazil, we don't have this distinguished in the Constitution. It's important for you to understand that. It's important for you to understand that why here in Brazil the legislation and the legal system has been making decisions as it has been. This is related to this right that's ensured in the Constitution. Article 197 establishes the public relevance of all healthcare services. So here we are talking about the lack of availability of services, both for public and private initiatives. And so this will somehow serve as the basis of how the legal system is going to behave facing healthcare related matters. So universality is under the Constitution, and the text says that health is the right of all. It's a duty of the state, and the state must ensure universal, equalitarian access to actions and health services. So the idea of universality is a principle, it's a pillar in the Constitution. And the first distinction that we make in the field of law is to make this distinction here. It's important to understand that in healthcare law, we also talk about equality, the principle of equality, which in law is more related to material equality. The idea is that not only people should have access to healthcare, but whatever is offered by the system can be adapted to the individual needs. Because each body is different and it has its unique characteristics and specificities. So there is a need for this adaptation. So universality is also a state duty to assist citizens. And in legal terms, we enable that someone can bring suit to make sure that if someone got this right, other person can also get this right. So this is the right of equality, which we also mention under the Constitution. In terms of ownership or title ownership, we question ourselves, who are these people who have the right to health care? We say that this is a individual and collective right at the same time. So my personal right will always exist, and the collective right will also exist, because healthcare is also a collective concept. And this caveat is something that I'm making because there's a line of thought that defends that the suits discussing healthcare matter, they can only be dealt with collective legal proceedings. The idea is that a class lawsuit would ensure equality in the system. I believe that in this sense, we can never exclude the individual nature of nature. We can say that we prefer collective and class actions, especially when it comes to the introduction of new medications, for instance. But class actions would be interesting for the collective good. Now, as for comprehensiveness, it's under Article 198 in the Constitution as a guideline of the unified healthcare system in Brazil. It talks about comprehensive service with a focus on preventive care without prejudice to any other services. Now, we have two main senses here. First one is the legal sense. It's a law that governs the SUS, talking about curative, healing, and preventive services in all levels of complexity. So the healthcare needs to be rendered in all levels of complexity in the system. So from primary care to high complexity treatment, so everyone must have this access. In the second sense, we can make an equivalence between integrality and the extension of coverage. And so this is the biggest field of judicialization in health. Here, we discuss to which extent the coverage of the SUS goes. So we discuss the exclusion of new technologies. We discuss whether the protocols of the SUS are, and protocols and procedures are up to date or not. So if we could reduce the discussions in the legal system, all of the suits that are brought in the legal system there, we would be able to put this all under the umbrella of comprehensiveness. In general, the jurisprudence has positioned in a sense to try to fix parameters. The idea is that comprehensiveness is not for all treatment under any circumstances, but we should have some pillars, some guidelines to go by. Finally, I think it's important to talk about the judicialization of health. This phenomenon has been related to the struggle for a better life, the right for citizenship. And here in Brazil, the legal system, what they did was the following. As the suits were brought to the Supreme Court, the Supreme Court takes a decision in the year 2000, and they stated that healthcare is an originary right. So it's a right that comes from the Constitution. Of course, this brought benefits, and judicialization allowed it more plurality, so to speak. And meanwhile, the judiciary was called to intervene in these demands. Together with that, the first lawsuits related to healthcare were made by plaintiffs that were HIV-positive patients. So their claims were for the public service to have the adequate drugs to fight HIV. So we had the first leading case there that reached the Supreme Court, and this made the public government to reorganize policies. And today, the policy in this area in Brazil is benchmark all over the world. And we have broken patents, we have produced genetic drugs, and a lot of this is because of judicialization. I know that judicialization sometimes compromises public spending or something like that, but we have to acknowledge that the intervention of the judiciary power is something that forced the public power to change the way that they dealt with these issues. Of course, I still have a lot to say, but I thank you for your attention. That's all I have to say for now. We thank you for the historic panorama that you have drawn, Doctor. It's a concern on the Federal Prosecution Office. We have a lot of us here in this event today, but jurisprudence is a concern. Jurisdiction is something that has increasingly been involved in the public health care policy in Brazil. I think this is a mistake. I like to believe that despite the difficulties, the geographic difficulties, the differences, the challenges in our human development indexes, but the thing is, we need to strengthen our collegiate courts and our other entities so that they are in the leading role of solving this problem. So the state, this issue is related to society, to enterprises, and many other entities. But I think this is something important. We in the public prosecutor's office, many times when we bring suit against the government, we do so because of the lack of action on the part of the government. And this is some constructive criticism. About 60% of this judicialization happens due to public policies that have been approved by the system but haven't yet been implemented for many different reasons by managers. And then our colleague Elida yesterday talked to us and answered this question a little bit. She said that this is pretty much related to financing. I'd like to say that this event is being broadcasted on air, and it's been transmitted for the entire world on YouTube as well. So we're going to continue this panel with, I'll give the floor to Dr. Silva, and he will have 15 minutes for his presentation. Good afternoon, everyone. First of all, I'd like to greet my colleague, Dr. Gilmar, and the sponsors of this event, ALMG, the World Bank, and other sponsors. I'd like to greet our foreign participants. You've come such a long way to make our event even better. And I'd like to greet my colleagues in the public's prosecution office. And I'd also like to apologize with the translation crew, because we are speaking very, very fast. Don't steal any of my minutes, please. I will try to talk about the right to healthcare and comprehensiveness. I have to say that until the beginning of the 20th century, healthcare in Brazil was dependent on charity, pretty much. So we had a movement in the 1910s and 1920s that they created the pension funds that were institutionalized in the late 20s. But these pension funds, they were targeting only their employees. Whoever was not an employee in a company that had one of these funds was uncovered. Later on, these funds were transformed into what we call the APs. And this also excluded anyone who was unemployed. These people that were unemployed, they would still have to rely on charity related to religion, religious groups, and many other groups. But ultimately, charity. These funds went bankrupted. Some of the money went to the construction of Brasilia, the capital of Brazil. But after a while, we managed to create new funds, and we created other institutions that substituted all these funds so that all Brazilians who were formally employed would be covered in terms of health care. In the mid-70s, we started with the health care reform in Brazil. This was a fight against the military dictatorship in Brazil. It was part of the struggle against the dictatorship in Brazil. And the format that the movement fought for was something that was included in our Constitution. So we were able to reach the universal right for health care. So, I'm sorry that you are very far, but the number one says that Brazil has one of the pillars, the dignity of the human being, and to promote the well-being of all. And another guarantee is and a guarantee and fundamental right is health care, and it is so for everyone that lives in the country, and it's related to the right for life. And finally, it's under the competence of the state to legislate on matters related to health care. So, if all levels of government, union, federal, state, and municipal levels were present there, they are all co-responsible for ensuring the right to health care. Here we have Social Security in Brazil, which includes social assistance, social security, and health. And within that, we have a specific chapter for health. Health is a right of all, and it's a duty of the state. So Mariana has also mentioned that. So who makes public policies in Brazil? In Brazil, the legislation power can make public policies in Brazil, and social policy is also made by the executive power in Brazil. We elect governors, mayors, congressmen to create and execute this legislation. In Brazil, we have several acts that deal with health care. We have the Organic Health Care. We have the Healthcare Financing Act as well in Brazil, all of them dealing with the same matter. Then you have the Unified Healthcare System. So, there's a difference between universal coverage and universal access to health care. Because of our Constitution, Brazil has chosen to have universal access to health care. The system that we have now is not a universal coverage, which is the model that is suggested by the World Bank and the World Health Organization. So the Brazilian SUS system, you have the following there. The services have to be provided within the network. It elected principles of equality, universality, and comprehensiveness in the rendering of services. So when you talk about universality, what it means is that whoever is in Brazil can must be assisted. Even our neighbors from Paraguay, if they are in Brazilian soil, they must be assisted by the SUS. The judiciary wants to interpret comprehensiveness that goes beyond what is possible, and that's the big problem that we have. So the complementary health system and the private health care. Brazil is a capitalist country, but that doesn't mean that you can't make supplementary or complementary or private medicine in the country. So the complementary system has a private nature, but it takes part in the SUS through agreements with NGOs. The thing is, if you don't have enough, if you can't suffice to cover for everyone, you're going to complement that with the private sector. For instance, people in Brazil, they have private health plans, health insurance. I'm sure that most of you who are sitting here today do have a private health care. Finally, here we have a private system. This is people that pay for everything that every service that they use without any plan or anything. They pay for it on a private basis. All of these plans are subject to medical councils, regional medical councils, and everything, and there's a number of rules they have to abide for. Now, what I have to tell you is that as a member of the public ministry, of the prosecution office, I am obliged to abide the law. This is my professional duty. But as a citizen and former president of ANBASA, I can have a different opinion. And I'm absolutely against the universal coverage in healthcare, because the idea, the concept is that everyone should have quality healthcare services whenever they need, without hindrance to their economic funds. And to that effect, you will enter the I want to know if the market is going to very remote areas of Brazil to assist patients in need there. No, they're not going to these remote places. These places are only covered by the SUS system. That's it. So, comprehensiveness. If you want to know the debate about coverage and comprehensiveness, we have dozens of papers in sites such as Cielo, PubliMed, and the website, the NGOs that deal with public health in Brazil. All of these people are against universal coverage for the SUS system. I'm not going to get into details because this is a huge debate and very interesting one. You will find some arguments in favor of unified coverage and against. So the possible comprehensiveness. So how are the policies ensuring comprehensiveness? Some people have understood in the past that the SUS is everything for everyone. This is impossible. You have everything that is possible for everyone that needs. That's more close to reality. But the public policy has been formulated. Comprehensiveness is written in our legislation, and so when they talk about the right for everyone to have coverage. This is this. So they also talk about therapeutic procedures. They say that the SUS is ultimately forbidden to sell or to distribute any medication that is not approved by Anvisa, by the Brazilian FDA. But some judges will say that trial medications, for example, are to be given, and they haven't been approved yet. So this decree has created hundreds of actions and services. So if you are a physician working for the SUS, you have to consider all of these aspects. We don't have a more democratic system than that of the SUS in Brazil. All the decisions are made in commissions that have the participation of all the different players. It's a lot of democracy, sometimes even too much. But the states and municipalities can adopt specific actions beyond those specified by the federal government. So if the state and the municipalities do have money, they can assume that cost, no problem. This is not against the Constitution at all. Now, the renome is this decree. We have some medications that are approved by Anvisa, the Brazilian FDA, but these medications are not included in the list of medications provided by SUS, because the SUS system makes tests about the effectiveness of certain medications, and if this effectiveness is not proven, it's not going to make the list. So the possible comprehensiveness. Very few people know this. Look at this. Forgery, changing products that are whose purpose are therapeutic. The penalty is 10 years in prison plus fine. This is more than homicide in Brazil. In Brazil, if you kill someone, you're going to prison for 8 years. No. Here you have those who are subject to these penalties. You have here the prescription of drugs that are not approved by the Anvisa, the Brazilian FDA. So if the doctors prescribe this forged or phony product or unregistered product, the physician is committing a crime, and the punishment is 10 years in prison. This is comprehensiveness. The Brazilian state have the duty to provide these services and to provide certain medication, and it will do so based on the legislation that governs these matters. And the executive power has given them this legitimacy, and it's legitimate because this was done by congressmen that were voted to be there creating the laws. I'm sure that this is our comprehensiveness. Anything beyond this would be an imposition on healthcare management, an imposition of breach in the principle of independence among the three powers in Brazil. What I have to say is that citizens sometimes arrive in the judge chambers and they said, if you don't get an injunction for this person is going to die. And then the judge will grant the injunction, right? You know, sometimes you have to get money from the government to save this person that needs the super expensive medicine. Well, of course, everybody wants to fight for life, but these are people who have access to the healthcare. These are not underprivileged people. This is Sophia's choice. You have to choose who is going to live and who is going to die. This is the tragic choice. And the physician is the one to make this choice. The physician is going to say this one is more likely to live and this one isn't, and they will decide it. And since our healthcare management is often presided by physicians, they participate in this management. I have this is a mention in that movie, Sophia's Choice, with Meryl Streep and all, and she has to decide whether the boy or her girl is going to die during the Nazi time in Germany. It's a difficult choice. There's an insurance called functional independence and neutrality. But I'm happy to say that everyone today is organized, that we overcome all these challenges through symposiums such as this one, mediation forums, which are held all over the country. And the idea is for us to do this in a very solitary way and cordial way, which is a characteristic of the Brazilian people. Thank you very much. We thank you for your participation, Dr. Osvaldo, for this much-needed reflection. Before we continue our program, I would like to make a reflection, especially to our foreign panelists here. We salute you, we greet you, welcome here. But the thing is, the comprehensiveness in our Constitution has another meaning as well. It's a meaning of hierarchization of assistance. Integrality is in all levels of assistance. I forgot something. When I talked about judicialization, I don't mean the right judicialization. If there's a medication in the list and the healthcare managers not offering it, you have to bring suit. What we are talking about is procedures that are unauthorized. They haven't been authorized by the Anvisa, the Brazilian FDA, and also drugs in the same situation. But now, when the procedure or the medication is listed, it's just fair that the person will bring suit when it's not made available for that. What we do have to do is to limit the granting of injunctions of unlisted medicines, drugs. So the comprehensiveness in Brazil is also related to the hierarchization of services. That is, as a user can enter a system, we mean that they have to have a comprehensive treatment considering the diagnosis. with cancer diagnosis, for example, after the biopsy and the proof that they have the pathology, the treatment has to be comprehensive, including appointments, medicines, surgery, chemotherapy, and radiotherapy. So this is the concept of comprehensiveness in the Brazilian unified system, the SUS. I'm very honored to have been coordinating this panel. I'd like to highlight Mr. Roberto Iones from the World Bank, not the Central Bank of Brazil, the World Bank. I'm sorry, I was mistaken first. Renato Dresch, also a judge with the Justice Department, and Antonio Jaz, who's always host and is a congressman who's our host here in this house. We are going to have a Q&A for panels 2 and 3, and I'm very honored to call Judge Vandre here to coordinate the debates on panels 2 and 3. Thank you so very much. I would like to invite the following countries to sit up here in the panel: Costa Rica, Uruguay, and Colombia, please.
Nós vamos iniciar essa parte de debates.
So we are going to start our debate with the oral questions, please. So the first question is made by Herbert Pereira from the Sergipe Legislative Assembly. Please come to the mic. This question is for the entire panel. Good afternoon, everyone. I believe it's good evening already. As you explained, you mentioned the social agreement, social pact that needs to be done with all the nations so that we can come to an ideal model that would include universality and the possible comprehensiveness. As I see it, the background of this discussion is the concept of state adopted by each nation. And when you talk about broad social popular participation in discussing this agreement, this pact, I am much concerned to see that in my country, for instance, most of society doesn't understand which actors will be part of this agreement and what are their interests. So I ask myself how this participation is going to be made effective and conscious. We know that are more liberal impulses that prioritize private sectors. Market have their own interests. Government have their own demands, their own interests. And the population, even though they might not understand how the structure works very well, they also have their demands, especially because they are the users of healthcare, in fact. So my question is, when you talk about possible comprehensiveness, this elastic concept of what is possible, in Brazil, we always pump into the concept of what is financially possible. So every time the state is requested and is asked to provide for what is possible, we bump into the concept of what's financially possible. And we come across the importance that the government gives to this, to healthcare. So this background of the concept of what the state is, do you believe that this is clear for the population, or do you believe that we are going to continue this struggle between the different ideologies? Vamos começar pelo. Let's start with Roman, who's in the further end of the table. Well, about this point, I would like to talk about two things. The first one is that you must have a social pact, a social agreement. Today, it's not possible to think about another way to come to an agreement. So the society has to participate. This is not a matter for technicians, for bureaucrats. Today, we can't decide where and how people are going to live without the participation of people. So if you're deciding which diseases and which medications are going to be included, we are defining things that are going to affect people's lives, and people have to participate. So I believe that this requires a very broad debate among all different interest parts or stakeholders in the process. Secondly, it seems to me that there's a basic rule. There is a difference between privilege and rights. When the system gives something to someone, gives a benefit to someone, and it's a benefit that cannot be given to other people in the same situation, this is a privilege, it's not right. And this happens in our society. I'm sure that we have an example of this in Brazil, and many examples. You send a patient to be treated, and the treatment costs $300,000. So can we provide this for everyone? If not, it's a privilege. So this is not the right path to go. So third, it seems to me that to properly define how much society needs to contribute, you need to include the judges. You need to include the judiciary power. So they can't have the argument that they are the ones who control everything and they're going to analyze and about what has been agreed upon by other sectors. This is not correct. They have to consider their sense of justice, and they have to ensure this social agreement. For me, this is very clear. Society has to be part of the process, and not only different stakeholders in the system, including and stakeholders are judges are stakeholders in this process. Does anyone else want to add anything about that? Very briefly. In Brazil, the SUS social control is made by municipal, state, and federal health committees, and they are constantly empowered. There are many programs for capacity building for members of these councils and everything. This is voluntary work. In many regions, you have to beg people to become part of the committee, and in other places, you have a lot of people who want to be part of the council. Other people just want to be part because they are looking at a political career or something like that. But these councils do exist. They provide health care plans, planning, actually. And so saying that healthcare in Brazil is at loss, it's something that is an exaggeration. I'd just like to make a reference because I talked about the social agreement, the social pact, and I saw some pessimism in that area. I think that the biggest challenge we have is to convince society that this is a good thing to this. And we have to do that before it's too late, because we'll come to a point of collapsing systems. So we have to include the academy, the executive power, the judicial problem, to include all these stakeholders, including also the industry, the physicians, users. And we have to include them. But how can we convince them that this is important now? Well, we are debating about what is financially possible. But what happens is we say that it's financially, we say that it's just financially possible, but people question that because they know that the resources are there. So we are going to come to a point in which the discussion on how these resources are going to be spent must be made. So I'm afraid that it may be too late for that, and that's why I'm saying that I'm a little bit pessimistic about this. We have to change the focus to a constructive pessimism so as to change our focus and try to build something. There are three things I would like to say. The first one is regards the concept of the state. What we see is that regardless the formation of the state and the resources, this won't affect the results in health. We've seen this morning, all throughout the day. Second, I'd like to talk about the level of participation and participation, including the decision-making process. This is something that we can determine in the process. The social pact can have different levels of participation for the community and other stakeholders when it comes to decision-making. Finally, I'd like to talk about what is possible. When you're talking about the financing, there are many questions we have to ask ourselves. So how much are we willing to spend? And who are those who are going to spend these resources? And where are we getting this funding from? So there are several elements that are always related to all of this and related to every participant in the healthcare system. Thank you very much. First of all, I might not have understood the question very much, but what I understand is you're asking how we are going to include all the stakeholders in this social pact. This is what I understood your question was. If it is so, I would say that this is a very deep question. because it brings a classic debate on political societies regarding the general interest and the interest of the majority. In an aristocratic country, in the ancient times, you said that if you believe something and the people believe it, it might not be good. But if the majority is the only thing we have to work with. So it's a dictatorship of the 51%, right? Now, as for examples, this year we had elections that were very surprising. In England, we had Brexit. In Colombia, the no has won. In the United States, elected Donald Trump. So we are going through difficult times. So what I mean is, a social pact is a pact between all the people. So a pact is not a contract between two equal parts. That's not it. What we need is for society to have a multilateral agreement, and we can give our opinions. This is how democracy happens. So first thing we have to do is to vote. We vote for our representatives so that the representatives elected make these decisions. And we also have the right to monitor, to criticize these representatives and everything. And this is how democracy works. Thank you very much. It's the same thing that my colleague mentioned. As society is involved in the theme, I'm not talking about technicalities only. I believe that Latin societies have a problem regarding the construction of citizenship. This is a much more complex, it's much deeper. So how do we feel ourselves as a society and how we act before the state? Many consider that the state is above all of us. And many times we establish a lot of duties to the states. It's as if the state was living in a parallel universe, and that's utopic. If the person doesn't see the state as part of themselves, who's deciding how resources are going to be used, it's very unlikely for the social pact to be positive. I believe that we have to advance in building citizen participation, and then with that we can form a social pact, and you can make this pact possible. The next question is oral. Jose Orlando Costa, I urge you to be very straightforward. Please don't make considerations because we do not have a lot of time left today. So 2 minutes, and that's a maximum. Good afternoon. My question is the following. We know that we have the social determinants in the Brazilian Constitution regarding health and housing. So there are a lot of things related to the right of health. For you to enjoy the right of health, there are other rights related to that. We know that environmental companies, behavioral conditions are also, biologic differences are always very important. So why do Brazilian judges decide based on the municipal level managers? They never consider state and federal municipal managers. So it's easier for judges. It's closer to their court, right? So why don't they involve the state and the union in that decision? Why do they only address the municipal secretary of health? Why don't they approach the state and federal levels?
So now, I'm going to answer this question. First of all, the demand is addressed either to the union, to the state, or to the municipality. If we talk about the joint liability, then the demand is based on the three of them, is addressed to the three of them. The judge may threaten, saying that the money will be blocked, favoring those who claimed that I'm totally against threatening managers with prison. I understand the monetary block, but that this should be presented to the municipality or to the state. The union is, in instance, that's much farther away. But the state attorney's, the federal attorney's office, the prosecutors are threatened also, and habeas corpus is achieved by all of those who were threatened in such conditions. A while ago, the State Secretary of São Paulo was worried because there was this arrest warrant issued by the federal prosecutor's office, and I told him, "Oh, don't worry, you're not going to be arrested. The crime is not, it doesn't have a high offensive potential, so you're just going to testify and then you go back home." So this would be the issue. The demand is usually addressed the municipality because it's closer. And the Article 137 from the Federal Constitution says that the municipality cooperates technically with the union. Technical and financial cooperator, but the one who exercises it, who executes it, is the municipality in terms of the health services. Congressman or State Representative Antonio Jorge, do you have a question? I believe that you had a question.
Deputado Antônio Jorge vai ter que ser aqui no pedestal.
State Representative Antonio Jorge, if you can step up here, please. We are no longer receiving questions. Well, once again, I'd like to congratulate all the speakers, our Brazilian colleagues who have honored us with their presentations. We're very proud of their talks, but I'd like to get back to a provocation related to our topic, the main topic here at this event, possible comprehensiveness. Osvaldo was very precise, considering his expertise, when he said that everything that is possible is well regulated. And I agree with him. The unified health system, clarifying that to our foreign guests, we have norms and rules for everything. Our normative, we have an impressive normative furor, actually. But this topic of possible comprehensiveness that I'd like to hear from was maybe Mariana and Osvaldo. Is related to what we should pay attention after almost 30 years of the unified healthcare system. Well, many friends here are venting here because, all they've been going through. The reality is such that we will have to leave some places, otherwise we're going to be living under an endless hypocrisy. And our Uruguayan representative was very precise when he said that for prioritized diseases or procedures, there's no judicialization. Here in Brazil, we are ethical enough to say that our system doesn't exercise any sort of discrimination, but we have 70% of the lawsuits related to ordinary issues because of lack of access. We're not talking about high-cost drugs or unlisted procedures. We're talking about ICU beds or access to ordinary health services. So either we mature to demand from the responsible players a quantic leap in terms of funding, or because this discussion on 10, 12, 13.5% won't solve our problem if we want to be as comprehensive as it has been defined. It has been defined. Now our dilemma now is to say we're going to have a social pact, because all healthcare systems are social pacts. Some have greater or less social participation. And if you allow me to say that, I'm using the prerogative of being a prosecutor, I'll just speak about it for 2 minutes. Our main challenge and our main motivation to organize this event with the presence of managers, the judiciary branch, and the legislative branch is that social contracts are healthcare systems in Brazil have a beautiful history related to the construction of the unified healthcare system. They must be complied with. It's useless to have a great social contracts, but ineffective contracts. And this is what we are seeing. And more we see that it's difficult to comply with the social contract. It would be more mature to acknowledge that the budgets are limited. The Constitution shouldn't be untouched in this way. We have to do something, and we have to look up in the international look up for possible solutions in the international experience. Otherwise, we're going to be fooling ourselves. Our unified healthcare system is going to be poorer and poorer, addressing poorer and poorer people. And the healthcare system will end up as not being desired by anyone. Temporal, Minister of Health, yesterday said that the first thing that the unions do, they should know more about the unified healthcare system. The first thing that they claim is a private health insurance. And we have to understand that comprehensiveness is one of our ethical strengths based on a constitutional principle. But we cannot achieve it because of sustainability and other issues related to our priorities in our state model. We don't prioritize social issues, but anyways, we have to rediscuss it. So I would tell Mariana and Osvaldo that it's important to advance in a more mature way in this debate, to change status, to truly have status changes. Portugal, if you allow Dr. Manotakina to anticipate what you're going to say tomorrow, in Portugal, we have co-payment, even in the primary health care, gratuity or free system doesn't really mean social fairness, and sometimes people who are able to pay and have private health insurance, most of them don't pay the income taxes that they must pay because they are waived of some percentage of the income tax because of the private health insurance they pay for. So things are wrong. We have to change them. I was looking for some words here, but well, anyways, Joseli, I have already answered your question. Dr. Oswaldo is telling me that I don't need to answer it, that on injunctions and habeas corpus, etc. Now I have a question by Dr. Oswaldo Fima from the Court of Justice here. In this case, the question is addressed to Uruguay and Costa Rica. In Brazil, almost all the judicialized cases are presented as urgent cases, and the only evidence requested is a prescription or a medical report. So there are judicial requests for immediate sentences. Does it also happen in Uruguay or Costa Rica? And I mean, what is the situation there? Thank you very much for the question. Regarding Costa Rica. In Costa Rica, there are 3 modalities of health plans. Drugs that are not covered, that are not listed, and the public health care system list. This list comprises some 550 drugs, medications. This is a flexible list. It's not, well, this is an open list. Some is a flexible list. Some cases must be accepted. So sometimes this is claimed judicially. Second modality regards waiting lists when the care provided is not timely. Let's say, for instance, that someone needs to undergo a cataract surgery and has been on the waiting list for 2 years, or when an MRI is not done or is done 6 months after the original prescription. Requests related to phytotherapy or treatment with dolphins and things like that. I mean, anything. Or because the woman is now pregnant, became pregnant and delivered a child, and the child needs this and that. Well, these are the types of requests that we get. So first, drugs or medications. Second, waiting lists. And third, some diseases that are not some procedures that are not covered by the system. Cosmetic surgery, for instance. Well, the system covers reconstructive surgery, but there's always a debate comparing reconstructive surgery and cosmetic surgery. For instance, mastectomized or women that have undergone a mastectomy require or are entitled to cosmetic surgery for repairing purposes, but I mean, it leads to some controversy here. The Constitutional Court receives all the cases, not because they have the monopoly of judging the lawsuits, but because they are quick in issuing their sentences. More than 90% of the sentence are complied with by the health authorities. So people see that some of the services may be granted by judicially. In the case of drugs that are not listed in the official list, well, traditionally the physician would just write a report and it would be accepted, even if there were discrepancies between what the treating physician wrote and the official list. Things are no longer like that, and I'm happy because I used to be a judge, and I I didn't agree with that. But today, at least, the treating physician must explain why he is prescribing such and such, why the alternative offered or supplied by the public healthcare system is not enough for his patient. And now we have an evidence-based medicine. It has been an advance. So today, the treating physician has to explain why, based on evidence. Now, in terms of the waiting list, what has happened? The appointment is scheduled, is appointment. The hospital complies with the sentence, but with the decision. But the ones that are behind in the list also sometimes also go to court, because there's a controversy here also, because who should be prioritized now? And in terms of uncovered services, well, the Constitutional Court does not receive these appeals or these suits, with some exceptions. This is what we have in Costa Rica in terms of health judicialization. In Uruguay, everything is simple. Only for non-prioritized services, a demand may be presented based on a medical indication, a medical report, and what the judge does is to request evidence, sometimes or usually expert witness that may come from the academia or a list of experts, and claim is solved within a relatively short period of time. The question now goes to Mariana from Vangvang, South Korea. He says that most of the participating countries provide healthcare services free of cost for all citizens, but in practice there are many barriers, such as a low coverage and what does the population think about the healthcare system? How satisfied is the population with the healthcare system?
Dr. Oswaldo, que traz os dados.
Dr. Oswaldo is showing me more precise data here, but I will answer criticizing some of the data that we hear about. He mentioned the IPEA and other surveys. The satisfaction rates are very high here in Brazil regarding the unified healthcare system. Now, earlier we talked about determinant factors. Education is a health determinant factor. We all know about it. So we could question to what extent the population served by the unified healthcare system is educated enough to truly criticize or to truly understand the system. I'm not saying that, I'm just thinking about how they position themselves when they receive health services. One thing is someone that has zero access to health to have some sort of access. Now, people with higher education that have access to private health insurance, for instance, may not be satisfied when she uses the unified public healthcare system because she's used with another type of service. And what we see in the media illustrates that quite well. We have some chaotic situations going on. The emergency rooms are packed with people. There's lack of beds. There are many problems. So it's difficult to talk about the satisfaction rates because we have the official data. But at the same time, if we ask, well, let's think about the critical mass that is here in this room. If we ask you guys what you think about the unified healthcare system, the SUS, we're going to have disagreement here. We're going to hear people saying that there are some islands of excellence in our system, the transplantation program, the STD, AIDS program. So it has to do with the universality principle. The system is universal, and the base is vaccines are supplied to everyone, and it's universal for higher complexity cosmetic procedures such as transplants, but everything that is in the middle leads to different rates of satisfaction. If someone lives near a hospital of excellence, then her opinion, her satisfaction rate will be different from someone who lives in a remote area that needs to be to commute to health center and will have to deal with transportation issues, etc. So it's difficult to distinguish here different satisfaction rates. But I'd like to highlight here that IBGE and IP surveys show that people are quite satisfied with the health services provided by our unified health system. I'd like to add to what she said. The unified healthcare system receives 12 million admissions, hospital admissions per year, almost 2 times the population of Uruguay and 3 times the population of Costa Rica. 1 billion procedures are performed every year. We are full of problems and we have to solve them. But when the system works well, the media doesn't say a word about it. They only talk about it when there are problems. When a dog bites a man, there's no news. But when a man bites a dog, then yes, it's on the news. So the media is working hard to criticize the unified health system. And this critical message is in this room is not it's not a way to measure things, because 90% of us here have private health systems. Myself, I have a state private health plan. I work for the government. I'm a civil servant, so I should use the public health system, but I don't. But in a country with 200 million poor people, I'd like to say that to my Korean friends. Well, you've given an example to the world. You've changed your country in less than 30 years. We have severe problems here. But the Brazilian unified healthcare system is the right way to go. Dr. Mariana will have to leave because she has to catch a flight. Thank you very much, Dr. Mariana, for attending the session with us. Another question from Monvam, from Korea, addressed to Uruguay. Dr. Arturo, I'm impressed with the fact that the Uruguayan healthcare system is different from other South American countries. In Uruguay, is there in Uruguay the national health insurance system? From as far as I understood, does it mean that all Uruguayan citizens must pay pay a contribution to the NHI and also co-payments to hospitals? Yes, it is correct that Uruguay has an integrated system with health insurance. All people with a certain level of income must contribute to the insurance. And if the citizen, especially if he or she has a spouse or children, and they contribute with a percentage of his or her income, co-payment goes to tickets or moderating fees, as we call them, for instance, to buy certain drugs or to perform certain tests. When we talk about co-payment, we talk about citizens funding or co-funding the health services received. For instance, in terms of assisted reproduction, when women want to get pregnant by artificial means. And well, that's basically what I said about co-payment. And well, besides that, we have the tickets and the moderating fees, and depending on what type of system chosen, this can be higher or less. But the idea is to limit the number of moderating fees, and some have been eliminated because they give they favor some pathologies, and also have established a cap for some services, which is 800 pesos. Because of the inflation, it is now less in real terms, in actual terms. I have a question to Dr. Agnaldo Ferreira. He's a judge at the Court of Appeals in the State of Minas Gerais. Well, actually, the question is addressed to all the speakers. In your countries, resources collected with the social security are used only with health services, or also pay for pension pension funds, or for pensions and retirements?
In Costa Rica, this is separated. You have some contributions for retirement and pensions, and it's absolutely separated from the healthcare insurance. There, the healthcare insurance is can only be used for purpose of health. It cannot be used by for any other purposes. It's unconstitutional to do so. In Uruguay, it's the same. So the social contribution of Social Security is also separated, and it's part of the funds to finance the system. The government and the government, employees and employers also contribute or pay for the other shares. So there is a very strong commitment on the part of the government to keep this system. 1st of July this year, we included lots of procedures in the system. We have procedures that are more expensive, and Uruguay is now at a level of income for retirement that is lower than the people that retired before them. So this might create a problem. So the government decided that everybody would contribute, and the government would enter with the rest of the money that would be lacking. So these pensions are, in Colombia, these pensions are separated, as well as occupational risks, and we also have coverage for traffic accidents and unemployment insurance. These are all separated. Each one of these items would have their own system separated. Question from Claudiana. What is the path for managers to address infrequent disease, rare diseases, considering the right to live? We don't want all for everyone, just what is needed for those who need it, according to their medical conditions. So, Dr. Osvaldo can answer this. This is not a bad judicialization. Considering our democratic system to control the SUS, it's very important to have the participation of the pathology society. These are NGOs to fight for patients that have some certain pathologies. Now, the path to address rare diseases must be given by managers themselves, not members of the prosecutor's office or federal governments. Some of these rare diseases, they are provided for in clinical protocols and other legislation, and other rare diseases or trial drugs, they might not be included there. So they might not be included. In this case, we have the good judicialization and the bad one. The good one is when you do have the procedure for the illness and it's not provided by the manager, even though it is listed. It is the duty of the manager to provide that. So you should bring a lawsuit for the government to fulfill their duties. Now, when you have medicines and procedures that are unauthorized, the position that we in the prosecution office have is that unauthorized procedures and drugs should not be authorized by judges in the decision to a lawsuit. This involves a lot of things. We need an execution of the budget, and these are always very complex issues. Luciana Lopes from the Minas Gerais Federal University. She's asking the following to the panel. If comprehensiveness is a polysemic concept, wouldn't the possible comprehensiveness, the use of this concept, be hinder the concept of comprehensiveness itself? Well, the thing is, we want to discuss what is possible in terms of comprehensiveness and what we have to consider as comprehensive. This was a discussion that we had when we were putting together this event. We discussed this with Roberto and a conference call and everything. So what we have today in Brazil, the legislation is everything for all. This is a mistake, an interpretation that, in our opinion, is mistaken. So we want to consider many other aspects. For example, now in the Supreme Court, there's been a discussion between some justices in how the expensive medicine is going to be incorporated. This has been discussed. I don't see this question as pertinent here. There's another question here: how to overcome legislation omission when you debate the model of the right to health care. Well, you have to choose your representatives better. We are in a democracy, so you have to vote in the right people, vote for the right people. We are not going to change the regime there. We have our town council members, we have a congressman on the state and federal levels, and so what I can say is vote for the right people. A question by the Mr. Lopes, academic director. This is addressed to the Costa Rican first speaker of Prosecutor. But the question is, according to the data presented, if you have more expenses, more spending in education and health, it didn't lead to more equity. Corruption is a big problem in Brazil. So how do we know whether the biggest spending isn't really effective? How can we know that if corruption hinders us from guaranteeing basic rights? Thank you for the question. There are two phases that have been presented in my presentation. One of them is that the biggest spending led to a significant increase in health services. But in the past 10, 12 years, however, the increase in spending in education and healthcare have not been reflected in better services in that sense. And if they haven't even reflected on social aspects and reduction of poverty, for instance, and there has not been an improvement in institutions. This happened essentially because in the past, increased spending would represent increased service. In the past 12 years, that was the objective. The objective was to improve the conditions of the educational and healthcare systems. I'm not discussing if this is legitimate or not. The thing is, the resources have doubled, and even so, this was not translated into an increase in coverage for healthcare, which was a pity, if you ask me. Things were done in a very imbalanced way. There are three ways to destroy a system. First one is by suffocating it. You reduce public funds for healthcare services and everything. So this is one way to destroy it. And then another way is to reduce it to the bare minimum. And this is what we do when we say that we are going to give everything to everybody, you know? So the demons of Dostoevsky always come to my mind when I talk about that. Dostoevsky says that he has been looking for absolute freedom. And when you do so, you find absolute nepotism. So when you look for absolute coverage, which are not really feasible considering our financial and social conditions, this is the best way to destroy it. And the third way to destroy a system is corruption. So in the case of Costa Rica, 12 years ago, we had very severe accusations of corruption in the country. And this involved people in a very high position in purchase of equipment and everything, being involved in corrupt practices. This was a very serious system, and it's something we've been recovering from. But we had an agreement between these parties, and we are in a transition phase now. But what I mean is, corruption can destroy, can suffocate the economy. So corruption can ultimately destroy the public or the private healthcare system. It will kill any social balance or justice.
The last question by Dr. Irma Machado from the Union of Physicians, the medical union. I'm going to address it to Dr. Machado. He will answer better than me. How does the World Bank help in the in terms of negotiations in the case of judicializations? Well, actually, I'd have to I don't know how I could answer that if I don't have a lot of time, but we'll talk about the experience in Latin America. The World Bank has created dialogue spaces. For the first time in our country, the judicial branch set together at the same table with the executive branch, trying to understand the different perspectives and trying to combine the two perspectives, the individual response given by judges and the collective response given by public policy makers. So there's this national dialogue and also international dialogue, and with what we have been learning is something that I said today. Judicialization by itself itself is not bad. Judicialization has some positive effects and also negative effects. Sometimes it mobilizes the executive, but sometimes it destabilizes the healthcare system. So we have to find a balance in terms of how we reason and how we look for scientific evidence to give a response to the disputes. So I think we have been generating space for dialogue, and each one of the players in the most participatory possible way should understand the other perspectives. We have to understand that this topic is a very complex topic, a multidisciplinary topic, and it also requires collective responses. Also, the experience, the Costa Rica experience with the World Bank, well, just to add to his answer, just like in Uruguay, in Costa Rica, the World Bank fostered a regional dialogue among the different parties, the main service providers, and other national players. I'd like to highlight one thing here. Something happened in Costa Rica. Judges were trained in evidence-based medicine with the support of the World Bank to go beyond just accepting the prescription written by the treating physician so that the judges would be based on the best possible evidence and add additional elements to the cases. We'd like to thank our audience for their contributions to the debate. The State Legislature of Minas Gerais, the Court of Justice of Minas Gerais, the Judicial School at Desert Fernandes, the State Attorney's Office, the World Bank Group, and our partner institutions express their thanks to the panelists, the authorities present here, and to our participants. I'd like to invite all of you to attend the coming panels that will begin tomorrow at 8:30 a.m. Thank you very much and have a great evening.
Bom tê-lo aqui.